You're listening to Power Athlete Radio, a podcast dedicated to empowering your performance every damn day. Join former NFL pro and Power Athlete founder John Welborn as he dissects the greatest minds in strength, conditioning, and more. So whether your goal is to be the hammer, destroy mediocrity, or simply move the dirt, you've come to the right place. Now with the warm-up done, let the gains begin.
We interrupt this episode for a shameless self-promotion. Everyone's a hero in January, but when it comes to February and beyond, not so much. If you want to be one of the few who punch the entirety of 2024 in its smirking face, then do it with Power Athlete. With an annual subscription, you'll get 365 days of performance-oriented programming delivered to your phone. It's like having a world-class coach, aka me, John Welborn, in your pocket for less than $1 a day. When you compare it to the month-to-month package, you're scoring a whole 2 months for free. And because I'm feeling extra generous this holiday season, everyone who signs up for a year before January 31st gets a training consult with me and my team worth hundreds of big ones for free. All you have to do is sign up over at www.powerathletehq.com/training. Don't be a just for January athlete. Commit to the cause with Power Athlete and crush 2024 like you hit it with a hammer. Remember, I'll say it again. That's powerathletehq.com/training. Now back to the episode. Hey, Power Athlete Nation. I have an interesting podcast and one that's very personal to me today with Dr. Andrew Koutnik. So as you guys are maybe familiar, maybe you're not, my son was diagnosed with type 1 diabetes when he was 5. He's 7 now. So this is something that we have dealt with hourly by the minute for the last 2 years and has become something that I didn't know a ton about, but since his diagnosis, learning to not only manage type 1 diabetes and understand the autoimmune disease that affects the pancreas, more importantly, the beta cells that produce insulin, which infect the alpha cells. And now you're trying to manage both insulin and glucagon, and you're using food and exogenous insulins to do all this and trying to really just micromanage this thing through a CGM. It is nothing short than overwhelming. So this podcast is very personal for me because we're having Andrew on, who is the top type 1 diabetes researcher out there right now in the game and a type 1 diabetic himself. Was diagnosed a little bit later than my son in his teens, but has since gone on and really just focused his life on not only understanding, but managing and doing research surrounding type 1 diabetes. He works for the Research Institute, where the guy was actually the creator of insulin. And they have an institute out in Santa Barbara that they brought him out as a researcher. So what we're going to do here today is we're going to dive in and dig in on type 1 diabetes, the mechanisms, how it works, and just this really personal, intrinsic knowledge that I have. And obviously he has, being a type 1 diabetic, and really just him, offering me information and really just kind of coaching and helping me how to manage my son's autoimmune disease. He has since become an invaluable resource for my wife and I, and we reach out and not only one of the smartest people we've probably had on the podcast, but also one with the biggest heart. So I thank him endlessly for coming on the podcast and also entering within our Power Athlete ecosystem. So if you guys are fascinated on type 1 diabetes and you want to jump in or hear a little bit about this journey that I've been going on and that he's obviously been on and more of the information, I want you to buckle up and tune in. It's kind of near and dear to my heart. My son is type 1.
Yeah.
So it's this incredible, like when I try to explain to somebody, it's like hitting a moving target where I'm on a boat, cause he's young and he's still in this honeymoon phase. And, because he's little, he can't necessarily eat enough food to sustain him. And then there's this weird thing with like glucagon where, now all of a sudden the beta cells affect the alpha cells. And now you're like constantly messing with this, like these crashes and this fasting. And it's, and the amounts he uses are so small. It's like half an IU of Humalog, and he uses, half an IU of R, and we use, maybe 1 or 2 IUs of like Levemir or Lantus. And it's this constant, like, and then, food, we follow the Bernstein protocol. Yeah. So he eats a high protein diet, low carb. Okay. Just because when we originally got diagnosed and I went in and we were, they get, he was in AK, his blood sugar was 300 and his A1C was like a 9. So he went into AK, he went in the hospital, they figured it out pretty quick. As I sat with the doctors, they told me that protein doesn't have an insulinogenic effect. So don't count protein in the in their kind of the way they count carbs, and this is how they dose for insulin. And I was like, so wait a minute, fat and protein, you don't think release insulin? No, only carbohydrates release insulin. They're the only thing that affect blood sugar.
Yeah, that's definitely not. That's 100% not true. Yeah.
Oh, well, it's 100% not true, and I knew it wasn't true because not only did I test my blood sugar when I was playing in the NFL, because I had this. Yeah, I mean, obviously I had this performance company, and as I played in the NFL for 10 years, I had a doc who was like real big on performance. So we tested blood sugar. Like I had all this intrinsic knowledge, and I was like, this is completely fucking wrong. I get on and I look at the American Diabetes Association, and for most people that follow their diet, they have a life expectancy of about 50 years. They make it into their 50s, they lose toes and this, and I'm like, this is awful outcomes. Yeah. And so that's where I ended up going to the Bernstein stuff. And I was like, well, at least these people have consistent blood sugar, which, as you know, consistent blood sugar reduces inflammation, and really it just becomes a much better effect. But he's still in this weird kind of honeymoon phase where like it's so malleable that like different foods affected. And I think a lot of the people that go to the Bernstein stuff went to the ADA first. So, their cells are burned out. Their body produces no insulin, where for him, he's still like out of nowhere, all of a sudden it kicks in, decides to work. And it's like, and it's like pork and chicken and beef. I mean, it's incredible to see seasonings and how they pair this and this. It's like a full-time job trying to manage his blood sugar for two parents.
It's 100%. John, as you know, as a parent, it's 24/7, 365 days a year. There are no breaks. You might feel like you can take a day off, and then that's when you'll be surprised every single time. So it takes a hell of a lot of resilience. I have it myself. I'm not a parent, and I can only imagine if one of my sons did get diagnosed, how different it would be for me. Honestly, the journey. But it can be often overwhelming. I remember when I first went in the hospital when I was diagnosed. My A1C was north of 8, and my blood sugar at that time was 560 something. I forget the exact number at this point. That was back in 2006 or 7.
How old were you?
16. So I was almost 17. I had almost turned 17 years old. And now at this point, I've had diabetes north of 16 years, almost 17. And actually right at over 17 years now. And it's been a hell of a journey, man. I will tell you, man, you brought up so many things. I could go like one by one on these things. But like to your first point on protein, there's been studies back to 1980s. I think it was 1982 by Collier, who directly showed you get 50 grams of carbohydrates, compare that to 50 grams of protein, like real whole food comparison. And protein has about 40, not quite the response on insulin that carbohydrates do, but about 40% of it. Yeah. So it's meaningful. It's different, obviously, as you know. It's much lower amplitude, but more prolonged. I mean, we're talking 4 to 6 hours. Although beyond hour 3 to 4, it's not as meaningful, I guess, unless you have quite a hefty bolus of it, and then you might have delayed absorption that may affect things. But yeah, carbohydrates, protein, fat, these all have independent effects that interact with one another when you consume them at different amounts. And there's a list, as you know, about 40 plus things that could change how that 1 IU or half IU insulin that you just took could affect the next meal in the same day. Or you do the same thing the very next day. You did everything you could to keep everything the same, and it's not the same. I mean, that is you can almost define type 1 diabetes like this. And I don't think a lot of people quite appreciate, one, how unique it is. A lot of people see the elephant in the room of type 2 diabetes, which is 90 to 95% of people who have diabetes in the world, and think of type 1 diabetes as this rounding error, unique situation. But people with type 1 diabetes, with their primary issue, of course, is you lose beta cell production of insulin. So you kind of lose your thermostat, so to speak. When the blood sugar goes high, insulin's automatically produced for most people to bring it back down. And when your blood sugar goes low, your body stops releasing insulin, so it allows it to come back up and releases other things like glucagon and catecholamines. And you have this self-regulation of glucose in this homeostatic range the vast majority of your day that a lot of people will never appreciate how important that is until you lose it. And when you lose it, that's when you can truly appreciate just how important glucose and insulin can be to your day in and day out experience, your quality of life. And A lot of people don't really appreciate this, even those with type 1 diabetes in this community, but how far reaching the implications of not keeping that glucose in a tight range can be years down the road. And the numbers you're putting out are not at all off the average of what's put out there. These numbers in developed countries are 11 to 18 years of reduced life expectancy.
Yep.
More life expectancy reduction if you're female, more life expectancy reduction the earlier you're diagnosed. And almost all of this can be attributed, not all of it, but a large portion of it can be contributed to this metabolic memory and accumulative effect of glycemia, or dysglycemia is probably the better way to frame it, on your overall health. And the number one cause of death with people with my disease, with your son's diseases, and people living with type 1 diabetes is cardiovascular disease. Diabetes is the 8th leading cause of death, but people aren't necessarily worried as much about, quote, diabetes. They're worried about the implications diabetes will have on them and other components of their life. Who cares if I have diabetes if it does nothing to me? We only care because it does do something to you. And the numbers are pretty stark. And I've essentially committed my life. My family's number one, and then everything else I do at this point is completely committed to try to improve outcomes in people with type 1 diabetes. I believe wholeheartedly in it. And John, to your point, it's kind of hard not to. It frames your entire day. Yeah. And it's hard, probably not the word, impossible to ignore. And if you do ignore it, it will remind you really quickly that it's still there. So, yeah, I resonate deeply with your experience.
We interrupt this episode with a shameless self-promotion. Power Athlete delivers battle-tested performance programming for every kind of athlete. So do you want to go from average Joe to MVP? Then dominate with Field Strong. Get stacked and jacked with Jack Street. Hustle in life and still build muscle with Grindstone. Fear no opponent with Dragon Slayer. Be harder than coffin nails with Hammer. Max out minimal equipment with Lean Enable. Or unlock those newbie gains with Bedrock. Get over to powerathletehq.com/training and choose your 7-day free trial right here, right now. Get lifting, get training, get in shape, all while listening to the rest of this show. Yeah, it has been by far one of the most painful and frustrating things that my wife and I have ever been through. It's, he's got a CGM on 24 hours a day, which means that he has to have a phone next to him all the time, which now he's turned it into his own like personal education communicator device. And I'm like, dude, don't give a 5-year-old a phone. And I'm like, there's no other solution for it. We locked it in this, and there's like, and then it's hitting us. And then in the night, we're pretty good. Like his A1C is a 5.1.
Wow, good for you guys.
Yeah, my wife is like manages it on a spreadsheet.
Hold on, John. I have to interrupt here. You know how incredibly rare that is to achieve that. Less than 1% of people achieve that, and less than 0.01, I believe, of pediatric patients achieve these numbers. This is actually it's certainly less than 1%, but that's an incredible achievement.
Yeah. So when we go to the endocrinologist, they are, always like, they pull CGM numbers and they're like, wow, this is incredible. I think part of this comes from, through Power Athlete, I've taught hundreds of seminars around the globe, and there's always been a nutrition component. And I've always talked about, high blood sugar and especially your response to it, and how well, related to muscle mass, being much more insulin sensitive. And, some of the research I read early on that talked about blood sugars consistently over 140 causes degeneration of the optical nerve. That's where all of a sudden people start getting cataracts as they age. And so I think that piece of my talk, my wife had probably heard ad nauseum. So in her mind, she has this kind of like anything over 140 is causing problems for him. So like the ability to balance him and, keep him somewhere between 80 and 120 all the time, and really trying to like micromanage this in real time has become, pretty much her full-time job and mine as well. But now all of a sudden he goes to school. So he goes to a private school where, there's 9 kids in the class, and, the teacher has a type 1 kid. And so he can pick up the phone and call, and his mom can call. They have insulin there. He doesn't have to go to a school nurse. So, we had to send him to a specific school, because when we looked at public school, they're like, well, he's not allowed to have his kits with him. The nurse has to have him. If there's a problem, he has to go. And I'm like, this doesn't work for us. So now he's got to go to a specific school. My wife packages all, makes all of his own meals. So everything we eat at home. So the minute that we go out, now all of a sudden it's like playing Russian roulette. You're talking to him. You're like, okay. And then the fat content in meat completely messes everything up because it slows absorption. And I also think he has some gastric emptying issues because, he's got some gut issues. When he was born, he got at 10 days, ended up getting staph in his belly button, had to go into NICU, and they pumped him full of all these antibiotics. And I think what it did, it just killed his gut. And so a lot of the issues that I've seen, especially with the gastric emptyings, is very inconsistent for him. So if he has, let's say like a filet, which is super lean, that's one thing. If you were to eat like a ribeye or something else, like a brisket that might have more fat, now we're looking at a completely different deal. Like baby back pork ribs or chicken in this, turkey. We have all of these foods and we've tracked them pretty well. And I know what the insulin response is going to be. So then you're dosing them, but then you go out to dinner and they put a big bowl of chips there and his sisters are crushing the chips. And he's like, I don't get any chips. I'm like, well, daddy and mommy don't get any chips. We'll yell at them later. So then you're trying to like get everybody to eat like this because he's still a kid. And then, birthday parties at school. So then my wife gets these like special gluten-free, sugar-free like cakes made and they're in a freezer and he gets one of those. You're trying to micromanage this with a kid and he's the toughest fucking kid I know for the mere fact that he has to probably get anywhere from 6 to 20 shots a day. He doesn't even fucking flinch on them, in his stomach in this. And he just basically has to manage this. And he's got to carry a pouch of ground that has, jelly beans and glucagon and is the whole thing. And, he's got a phone and, we were at basketball practice and he comes over and he's like, I feel low. And I'm looking at it. I'm like, you're 73, dude. There's non-mediated glucose uptake where now when he starts to exercise, that pulls his blood sugar down. So now all of a sudden we've dosed him, he goes and he exercises and that crushes him. So now all of a sudden now I'm like, okay, I know that 2 jelly beans moves him up 15 points. And you're like trying to like micromanage this thing in real time. And it's fucking awful. And my heart breaks for him every single day. And I told him, I'm like, there is going to be a cure for this and we're going to find it. And if I got to talk to everybody on the planet, we will find the person. And so he told the endocrinologist, my dad and his friends are going to figure out how to cure this. And the guy and the endocrinologist told my wife, he's like, you can't tell these kids this. And my wife's like, no, they're going to figure it out. I think that they are on the cusp. We went and talked to a doctor who's proved that he can regenerate organs. A guy named Adil Khan, he's in Canada, just approved for a grant where he was able to go and prove that he can regenerate 10 organs. And has done it clinically and has run trials. So he can repopulate the pancreas. The problem is that fixes type 2 people. But as you know, type 1 has an autoimmune trigger. So now you got to figure out why the autoimmune cells are killing the beta cells. Yeah. So like that's the next conversation. But I look at this outcome and more importantly, as you said, when you start looking at the research and the outcomes of what this looks like over a lifetime, the only way you can do it is by, I think the way that we're doing it, which is fucking micromanaging. But what happens when he becomes 16 and 17 and 18? Does he continue with it? Or he's just like, fuck it, I want to go out and be a normal kid. And I don't think anybody until you happens to you or like it's happening to us as a parent understands the magnitude. You do 100%. I can see you nodding your head because you're probably going through the same deal in your head. But it's like when I try to explain it to people, I'm like, even air travel, like, oh, we should go on a trip. And you're like, well, shit, if we go on the airplane, his blood sugar is going to be fucked up for 3 days. We're going to be in a foreign country or a place that we don't know what's in the food. So now all of a sudden, and then now, traveling with the pens and do they go bad and this and like, there's like 4,000 things that you're trying to take in. And every time you sit down at a meal, you're doing this math in your head and being like, what can he order? What can he have? What can this and this? And it's, you just want them to be kids. Yep. This episode of Power Athlete Radio is powered by Train Heroic, the most immersive strength training app experience on the market. We've built an online training business by partnering with Train Heroic to deliver all of our world-class training programs like Jack Street, Hammer, Field Strong, and Grindstone. To learn which Power Athlete training program best suits your goals, head to powerathletehq.com/training. And if you're a coach looking to build a business with the best training tech in the business, head to trainheroic.com/powerathletehq. And now back to the show.
A lot
So-
of people just, well, when they get diagnosed, and I think this all the way back to your original point of like 70 to 140 or going above 140. I mean, that technically time and tight range is what they call it. It's not time and range, it's time and tight range in the diabetes community from 70 to 140. And it's actually controversial to even say that something over 140 would be adverse. But if you look at, epidemiological data, at large studies that pull a bunch of data sets and look at the dose response of someone's fasting glucose level over time, you see that as you go higher and higher above normal, there are accumulative adverse responses. At least increases the risk of adverse responses in things like cancer, all-cause mortality, especially cardiovascular implications. And what's less controversial, though, is it's quite clearly having an implication on how you feel. These fluctuations do matter. It's not so much, you can go online, Google symptoms of hyperglycemia, symptoms of hypoglycemia. I mean, these are all symptoms of, a lot of people don't like hearing this, but like mental health symptoms. You're fatigued, you feel like, straight shit. And that's just the truth, And so a lot of people don't go into this thinking, okay, how is this going to implicate me long term? Because as you spoke about, you talked in your talks, obviously microvascular diseases, retinopathy, kidney or nephropathy, nerve damage, all these other things are very prone to high levels of glucose. They cause a lot of damage. As you mentioned, oxidative stress is probably the primary mechanism. There's other pathways like aldose pathways and whatnot that all accumulate to cause damage. But as you get higher and higher, there seems to be a clear dose response into how cumulative, how negative these are and how much quicker they come on. And, there's one of the largest and most expensive trials the NIH ever ran was something called the DCC and EDIC trial, where they had 1,400 patients with type 1 diabetes and they monitored for 30 years. And the only thing they were trying to prove in this trial, super simple, was do you inject 2 times a day or do you do more than 2 times a day in injections? And what they essentially proved is just by doing more intense insulin therapy compared to just 2 injections per day, that improved glycemic control, despite higher insulin load, despite higher BMIs as a result of that, so higher body mass. They had way better outcomes. It essentially proved that glycemia was one of the leading factors in microvascular disease, and also started to lend data to the idea that macrovascular disease, that glycemia has a clear role in there. And we know that kids within there's a lot of data that these effects happen pretty early, right? So like if you look at data, even in children with type 1 diabetes, and this is like the negative part of the talk, but the positive part of the talk discussion is that, it doesn't mean there's not a solution, right? There might, and that's a whole different part of this discussion, but, within 4 years, and it might happen sooner, these things might be happening earlier than we anticipate. It's just, this is the earliest they've captured subjects and looked at them post-diagnosis. They know that kids can see signs of subclinical arterial disease, looking at arterial stiffness, flow-mediated dilation, endothelial dysfunction, which is in essence the precursors to what would be long-term cardiovascular, hard endpoint macrovascular diseases. And that's within 4 years. We also know within 4 years that there's neuroanatomical changes within kids of type 1 diabetes. And you would not expect that this is because of some autoimmune overlap, because whatever caused autoimmunity is somehow causing these other issues. No. We know that glycemia is damaging to almost all these tissues, reduces cerebral perfusion. I mean, might contribute to altered bone growth because we know that it can disrupt the IGF and IGF binding protein axis, or at least it's associated with that. Related to exercise, there's some data that says that it can attenuate or cause deconditioning. The VO2 maxes of individuals who exercise at the same amount and of same athletic level don't have as high a VO2 maxes. Whatever you make of a VO2 max is still an indicator of fitness and not vascular function, but ultimate oxygen consumption rates. And those are attenuated. So a lot of this points to a clear implication of glycemia, but there's something else to appreciate as well beyond glycemia is when people look at type 2 diabetes and type 1 diabetes, let's say over here is type 2 diabetes, the big behemoth, the elephant in the room, and what's over 10% of the world population, over 11% in the United States. I mean, expected to double in the next 30 years. Looking at this, people have genetic and lifestyle factors, including increased fat mass, adiposity, that ultimately causes insulin resistance. that ultimately facilitates higher levels of insulin and higher levels of glucose because the insulin doesn't work as well and it can't keep up. So not only do you have insulin resistance, or higher insulin load in the peripheral tissues or peripheral vasculature, you're also having higher glycemia. But type 2 diabetes is confounded, obviously, by the genetic and lifestyle factors, by the increased adiposity, by the increased lipids, because it's not just higher glucose, higher insulin, higher lipids, higher amino acids that are sitting in the blood of individuals with that disease, at least many of them. But in type 1 diabetes, let's say over here, it's an autoimmune disease, largely appreciated as such. I mean, there's rare exceptions to that, but for the vast majority of us, it's autoimmune and killing the insulin-producing beta cells, as you mentioned, that again regulate glucose. And just by that, obviously, glucose just ticks up until you actually inject insulin. But as you appreciate, many in the audience may not know this, but the fastest acting insulins that we have as patients with type 1 diabetes don't work anywhere near as fast as endogenous insulin does.
Yeah. Yep.
And so, like, I don't know, John, your metabolic status or any things, but assuming you don't have type 1 diabetes also, because I figured you might have mentioned this, or type 2, you eat, let's go say we both go somewhere to go eat donuts. We probably won't do this, right? Both say we did. And we go to that store, we sit down, we eat those. Let's say we do 75 grams of it just to like match an oral glucose tolerance test, just for, shits and giggles, right? And so we consume that. And someone such as yourself, John, or someone else who doesn't have type 1 or type 2 diabetes, their body will detect that elevation in glucose instantly in the beta cells. Insulin causes a signaling cascade that will release pre-stored granules direct into the bloodstream, the hepatic portal vein.
Yeah.
Whereas
there's I mean, aren't there it's not sensors, but I mean, effectively, there's things in the back of the tongue that sense the sugar and immediately kick on. If you look at like the initial cascade effect, like you said, it's instantaneous. It's not even down the gullet yet, and it's already working.
Yeah, there's a number of you're talking about extremely complex changes that are occurring that from the second they hit the tongue. You even see this in athletes. Like you give them a little bit of carbohydrates as taste, you start seeing actual physiologic meaningful differences in performance, just not even by caloric consumption. So yes, there are changes that happen from the second you actually put it in your mouth. I mean, you actually have some digestion that's occurring within the mouth because of releasing from of some enzymatic breakdown of carbohydrates immediately. And so yes, there's a cascade of things that are happening right out the gate. And that allows that glucose response to be much more attenuated and controlled very rapidly. Seconds to minutes, we're seeing response. The second glucose level is meaningfully elevated. Sometimes you might not see much of an elevation, although with the donut, 75 grams, you probably will. But, let's say it's a mixed meal with fat, fiber considerations. Maybe you ate the salad first. You're delaying all the effects of glucose over time. And you might not see much of an effect in a normal, healthy individual, right? But in someone with type 1 diabetes, let's say the fastest acting insulin I got is it's not going to even hit my bloodstream for, let's say, 5 to 15 minutes. And then the peak might not be for an hour. And then it's not out of my system for 2 hours. I mean, the magnitude of kinetic difference between the insulins we have and how rapid the food is, at least in the predominant form of energy in most people's diets, which is carbohydrates, is stark. And largely why when you look at a glucose tracing of someone who has type 1 diabetes, on average, not everyone's different. Everyone does it their own way. We're not talking flat lines here. We're not even talking lines that look anywhere near the typical, what some people believe as normal fluctuations from postprandial food consumption with elevation and comes back down during the day. It's nowhere near that. I mean, we're talking the mean glucose of someone with type 1 diabetes is about 183. Mean HbA1c is around 8%. And we also know the fluctuations around those means is around 60 milligrams per deciliter. Obviously, normal glycemia for most folks is 70 to 120. That's definition normal glycemia.
Yep.
And if you look at actual CGMs as a direct comparison in people who don't have diabetes, those numbers look at right around 100 as the average, right? But you're lower at some points, you're higher at some points because of meal response.
Dude, I wore a CGM parallel to him. And So, I wanted him to see, hey, I wear it too. And so I had my Dexcom on and we would eat the exact same things. And all of a sudden, I see mine go up and mine was a little bit higher in the morning because I'm a big dude. As soon as I ate, it would just tank. And then all of a sudden we would eat the same thing and mine might go up to 105. And if I really pushed, I could get it to 120. I couldn't get my blood sugar over 120. And I'm like looking at him, and all of a sudden I'm seeing it go up. And, we know, like, I got to dose him beforehand, but then you're like kind of waiting. And then, how fast to eat, you got to give him 5-10 minutes, and then we eat. Yeah. It's to the point where I thought that it would be beneficial for me to wear it in parallel with him. And I was like, fuck, this is a complete waste of time. I mean, I just, like the metabolic flexibility to be able to process carbohydrate, pull it down, and what happens and maintain this. It's just like, I'm looking at him and I'm like, damn, this is funky. I also don't have any like the gut issues that he has, which I think from getting blasted from all those antibiotics is at 10 days old, I think has caused a lot of these issues. Yeah, dude, I am forever looking at this as like, in the analogy I give people, it's like being on a boat. You're trying to make a target shot. That's moving. This is moving. And especially for him, which he's still kind of in this honeymoon phase. I disagree with the endocrinologist. He's like, oh, no, he's out of the honeymoon. I'm like, dude, there have been days where he's eaten and I've actually waited to see, and I've seen his glucose come down to normal on his own. So
you can test that too. You can look at C-peptide, carbohydrate-induced C-peptide levels, and actually objectively assess that and find out. I mean, I'm well within the less than 0.1, like undetectable levels at this stage. So no one can make that argument right for me. But yeah, you can actually test that and show, hey, there is some production or not, and find out.
Well, and the biggest thing is, he eats a high protein diet. He's very controlled in the carbohydrate and the moderate fat, which is in the Bernstein protocol. Those kids that continue to do it, I mean, the only issue is the growth rates are a little slow. So they tend to have later growth spurts. When we look at what most kids his age eat, I mean, they probably eat anywhere from 300 to 400 grams of carbohydrates a day. And, if insulin and blood sugar is working, I mean, it's definitely a growth factor. I mean, insulin being a powerful muscle builder and size builder. So, I mean, is his growth a little behind? Yeah, but all the kids that we've seen that follow this Bernstein protocol tend to have big growth spurts later in life. So I was like, he'll catch up, Yeah,
well, I'll tell you that, and that's you brought up like I respect this, John. You bring up a lot of the topics that normally in this community would just be like a nuke dropped in the middle of a room. So the growth chart. So let's dive into that. The data on growth in general in type 1 diabetes is slightly delayed. Let's say there's a growth chart in someone without type 1 diabetes, and then you have type 1. It's slightly lower. And it's not completely appreciated why that is. There's speculation, you don't have the endogenous insulin production, or, this is such an anabolic hormone, or it's, it's some other effect of dysglycemia on anabolism or whatnot, which there is associated data for that. But one of the key metrics of growth, of course, at least bone growth, is IGF signaling. Not the only thing, right? There's clearly genetics is probably the most important thing of anything. And nutrient, so a well-formulated diet. If you caloric restrict, I mean, you are clearly going to have implications here. But let's say someone is having sufficient calories, everything else controlled, then IGF is a critical factor. And most of that from a nutrient perspective, assuming calories aren't restricted, comes from protein. And assuming you're not going on a full-out fast, you don't see much of an attenuation in these signals just by reducing carbohydrates. There's minimal data that anything meaningful would happen there outside of a caloric restriction. And the only data I've seen that there's a deterioration in IGF or key growth hormones is when you start looking at multi-day fast. Now, if anyone disagrees with that, please let me know. I'd love to see the data. I'm just unfamiliar with that. But the issue is that, here you're talking about a negotiation, John. You're talking about what do you do? There's data that associates dysglycemia with these key metrics of growth. So do you prioritize that? Do you prioritize protein? Do you prioritize this thought that insulin is super critical for growth? Insulin is much more potent to the adipocytes than it is for muscle. And IGF is much more potent to things like bone growth and muscle growth. Last time I was looking at this data, although it's in animals, so take it for what it's worth. It's not the data I'm referring to is not in humans, and that was, I believe, from O'Neill was the first author on that work. Very interesting, knockout models, all this kind of super refined ways of trying to truly elicit if there's an effect or not. But either way, that's a very controversial domain because people think carbohydrates are critical for growth. And there was a pretty prominent paper that really changed how people perceive very low carbohydrate diets. And this was out of a community group that follows the Bernstein approach. It was published by Duke, Harvard Med, and the community group itself, some of the key individuals in that surveying doctor-confirmed data. So actually looking at doctor-confirmed data from patients who were doing this approach, 42% were pediatric, and 30 or 58% were adults. And what that showed is there was no growth impairment compared to type 1 diabetes norms from pediatrics patients who were actually implementing this approach. So there actually is no data currently that it's impairing growth in the patient population of interest, which is type 1 diabetes. So
okay, well that's favorable then, because everything you talk about, like there's this key factor for carbohydrates for growth in this, and I've always said, I'm like, man, I always thought it was a protein deal. I've eaten a pretty low, carbohydrate. I mean, I guess as kids, we ate a ton more carbs. We just didn't know any better. Standardized diet in the 80s where, we sat down and ate a, fucking box of grape nuts, which is probably 300 grams of carbohydrate in one sitting with non-fat milk because you don't want the extra fat, right? But, I always felt that like a higher protein diet, like you said, IGF-1 was a major factor for it. But, the research is really, or not the research, but I would say the dogma is pushing towards, higher carbs, and that at least with the kids with the Bernstein, from what I've seen on their Facebook groups and this, it seems that these kids hit later growth spurts. And I just didn't know why that was. I mean, maybe it's just effective blood sugar.
Yeah, it's interesting. And I must unpack this a little bit more to be totally fair to the breadth of all the evidence, because what I refer to is the most robust evidence we have today. But some people look at that and say that's observational survey-based data, even though it's medical confirmed data. So medical records, we're looking at this. Some will argue that's a very biased population. It is. These are highly motivated people, as you are, and frankly, I am too. And so what else are they doing? Is there other factors beyond this that are playing a role? Because there is some evidence that came out earlier than this paper that, and I think it was in Australia this occurred, where the researchers actually surveyed all across, I believe it was Australia, all clinics that have any patients who were doing very low carbohydrate approach, and were specifically looking for adverse responses. And so they were specifically trying to understand, if someone did this approach, what are some of the adverse things that we might anticipate? And so it was, this is not to belittle that paper by any means. This is an observation. It's important to understand, but they were looking for that, right? So it's not like they just looked at everyone in the world and said, okay, these are the people we see, and this is their outcomes. This was looking for adverse responses. And what they were seeing is that patients did report some growth impairment, or at least relative to the norms. The problem was that almost all of them were either calorically restricting, or they were, caloric restriction was the main one, but there's actually some cases where patients stopped taking their insulin, so insulin cessation. So that's going to clearly impair growth, and more than anything. I mean, nothing quite is as powerful as a caloric restriction is on blunting all forms of growth. You can stimulate it to a degree, but that's an incredibly powerful way to inhibit that. So that can't be untangled. So this other paper had over 314 subjects, and that's a much more robust set of data. The data where people are really looking at and pulling the hypothesis that they may impair growth is out of patients with seizure patients, because this has been used it has got into major academic institute medical clinics as a use or treatment for drug refractory epilepsy, right? Yeah. Even though carbohydrate restriction has actually been around in diabetes hundreds of years earlier. So a lot of people believe that this was actually first discovered in 1920 by Wilder in the Mayo Clinic, showing that if you do a ketogenic diet, it models physiology of fasting, and that as a result had a beneficial effect on seizures. Well, that's definitely true that it happened, but actually if you look at the history of diabetes, carbohydrate restriction was actually standard of care back in the 1970s for both type 1 and type 2 diabetes. It was actually only post the discovery of insulin that really the mindset started to shift. So there was papers in JAMA in 1925, insulin's discovered in the early 1920s. About 3 or 4 years later, we start seeing physicians, prominent physicians, describing, okay, well, I'm seeing patients eat a lot more carbohydrates and take more insulin. They seem to be doing great. What's the point of restricting? Well, despite all this, John, despite the back and forth, despite this has been around for, frankly, 400 years plus, at least there's cited evidence for that. We don't have any randomized controlled trials long-term, which is what people look for. They're looking for these very controlled studies to really extract out if something is or isn't happening. There's plenty of examples of seeing observational analysis that aren't standing up to the test of a very controlled, randomized controlled trial. Maybe it's bias, maybe it's these other things. So that's where we stand. There's nothing over 7 days and less than 50 grams per day in patients with an RCT. But the best evidence we have today suggests that that a lot of these adverse effects are not substantiated currently. So we lack evidence to substantiate it. We also lack a lot of evidence to disagree with it. But we have to use the evidence we have right now, because as you've experienced, you came across this approach. I actually did it in 2013. I've done it for 10 years since that point. I was actually following a very whole foods ADA-based approach from diagnosis onwards. I actually have records of all this, everything up to that point. And for the last 10 years, I've controlled body weight, calories, essentially activity level all the way across the board. And my mean HbA1c at that time was 5.5. And either way, I say all that to say, I've done a lot of self-assessment. I'm only an anecdote, right? And this will come off to a lot of people as very biased, but let me back up. I'll leave my anecdote out of the story because I think that's maybe less important to this, and just say
actually, I think it's more meaningful. I like, so the anecdotal stuff with type 1, especially people that have gotten normal blood sugar and lived normal lives, to me is much more meaningful than getting bombarded with a whole bunch of research that supports a nutritional approach that I completely disagree with. I mean, with type 2 diabetes, and I've worked with several people with it, it's 100% a disease of carbohydrate. When we remove carbohydrate and they lose about 20 pounds, type 2 tends to go away. Unless they have completely fried all their beta cells with this. And I have a client right now who, they thought he was fried. He was on insulin and this, and now all of a sudden, for some reason, I call him Lazarus, his beta cells decided to come back and start working for him. But it was amazing that, he put on muscle, lost body fat, got in shape, did all the things that, the doctors are afraid to tell people to do because they know people aren't going to make a life change. So he made all these life changes. And now he's like, he was on exogenous insulin for almost 20 years. And now all of a sudden he loses weight, gets back in shape. And I'm like, dude, if your body, as long as there's not an autoimmune trigger destroying those beta cells, I think you can repopulate. And he's done a bunch of stuff to do it. But it's been lifting weights and training, sleeping better, micronutrients, getting his blood work done. It's been like a multi-prong attack. But to me, anecdotal stuff like that is almost more, beneficial than, these controlled randomized stuff, just because it's so hard. As type 1 is so malleable. It is, I keep telling people, I have not met a single type 1 that fits it all within the space of the other ones. There's a kid that goes to my son's school. He relatively eats a standardized diet, and his blood sugar is all over the place, and they don't manage it the same way. And, they think we're completely insane the way we manage it. And I'm like, yeah, but shouldn't my goal as a parent to give him the best possible outcome? And I know that the best possible outcome is to have a blood sugar that's between 70 and 120 for the majority, let's say 80 to 90% of his life. So anything that I have to do to micromanage that too, isn't that the job as the parent to give the kid the best chance to survive in face of this?
Yeah, wow. This is like dropping every controversial status. I think I will say that I resonate with that personally, because I know what it's like not to be in the normal range. I know what it feels like. It doesn't even have to be like, what's the long-term complications or any of those things. It's like, how do I feel today? And I know exactly how I feel when I start getting higher and higher and higher. I know exactly how it feels when I dip down fast. I'll know exactly what it feels when I get hypos. I know all these feelings. So when I ask a lot of people why they do this approach, usually has nothing to do with what's the long-term implications of this, as you're kind of alluding to there about what's the best approach for my son right now long-term. It's frankly because they want that day to go well. They want that day to be better. They want to feel better right now. And I think that the issue is that people do get, admittedly, even myself, you can get caught up in data sometimes. But one thing that I appreciate about my own personal experience is that oftentimes my personal experience has led to insights that maybe research isn't there yet. For me personally, it gives you an insight in metabolism. I'm sure you can appreciate more than you ever have in your life when your son was born, just how much you have to basically be an expert of your own metabolism, not by choice. You have to. And that regulation, day in and day out, all the factors that play into it are it feels countless, frankly. And like the other day, I go, sometimes I run in the morning. A lot of times I'll lift, switch it up or whatever. But, I try to keep it as consistent as possible. Life's not consistent. It throws curveballs all the time. But, the other day I went running. Most of the times in the morning, if I have that with like just coffee and a little bit of coconut cream, that I'll stay stable the entire time. Well, yesterday, nope, didn't happen. Tanked. And so that's type 1 diabetes, man. It's that day in, day out journey. But imagine you are the physician now. Let's flip the context. Right? Say that you are the treating physician and a patient comes in newly diagnosed. From all we understand right now, John, this wasn't their fault. This isn't something they did or they could have prevented. At least the data doesn't say we know exactly why. And so they're walking in with at least some awareness that, look, this isn't my fault. And at least we don't know how to prevent it. So how could it be, right? Sure. And then they're walking in thinking, okay, I'm the physician. How do I take this patient who is completely devastated by this diagnosis? They now have to live the rest of their life, as you mentioned, micromanagement. I mean, it's what it is. What it feels like. There's many people who cite anywhere between 180 to 300 more health-related decisions per day than someone with type 1 diabetes otherwise. And as a parent, that burden's on you as well. So you have all that combined. You're dealing with that. A lot of people's first inclination is to not say, suck it up, buttercup, here's the deal. For some people, that will hit hard. It'll work very effectively. So some people, you're trying to drag them out of the depths of where they are and give them the opportunity to feel like they got some hope. Because sometimes hope is more important than, this might sound bad, some really grim reality. Giving them the hope, giving them out of that situation so they can see clearly may give them that opportunity. And so they're up against that pressure to deal with that. And they're also up against that pressure to deal with that within a time constraint that the medical health system, to be honest, doesn't really give them the opportunity to really dive into every key detail. They're in there trying to give you the hard key facts, and they're also bound by standard of care. Yeah. So if they go off course, they have a medical license. They work 8 years beyond most people's educational training, grueling at that to achieve. And, now they're in a situation where if I go against this, I'm at risk. And so there's so many barriers to allowing for a more nuanced conversation in that clinic. And so it leaves it a lot of times, and this whole system kind of fails both sides of the equation, both the healthcare providers and the patient, but it leaves it onto very motivated parents such as yourself, John, the individual patient to really regulate this. And so you're not on your own, but damn, it sure feels like that way sometimes, And so, I resonate with the point of like, at the end of the day, your own personal journey and what you see works for you is always going to be king. And you have to look for as much information to try to get there. Maybe someone's completely rocking it with high carb. I can tell you my own personal experience is that I have done that before. And as a father, as a researcher with an unpredictable schedule, and my priority is not myself. My priority has to be for other people most of the time. And to show up and be intact every single day, to be on it, to not have minimize as much as I can this disease's impact on my life. I do everything I can to regulate that and do the best I can for myself. And so I resonate with your point to do everything you can to help better your child in the best way you know how.
We had on the podcast a number of years ago, we had a guy named Jim Abrams who started something called the Charlie Foundation. Yeah. As you know. And so this is long before my son was diagnosed. We just had him on, and 2 minutes in, I realized that he was the guy, the producer from like The Naked Gun and Airplane, and like
you didn't know that beforehand, John?
Well, no. So somebody put us in touch. Like my history, I played in the NFL, and my rookie year in the NFL, I got hooked up with a doctor named Mauro De Pasquale. And Mauro was the guy that did the anabolic diet and was really the father of carb cycling. So one of his things was, managing, high protein, moderate fat, pulling carbs in this, and really the insulinogenic effect of carbohydrates, especially in a depleted state when you're adding it back. And actually cycling the carbohydrates is a extremely powerful muscle builder. I completely, from working with him, I came in and started as a rookie, and then I got hurt. And then I had that off season off because I was on injured reserve, started training with him. And the year that I trained with him and we did all this carb cycling and all this kind of voodoo, completely like metamorphosized me as an individual. Like I, was about the same weight, but it was a completely different package. So I became pretty fascinated with this, and I can't remember how we got, and then I retired. I started Power Athlete. We had this podcast early on. I forgot how I got linked in with Jim Abrams. We had him on the podcast, and the origin story was amazing. He was at the UCLA Medical Center, and they were preparing to do a lobotomy on his son because of the severity of the seizures. He goes to the medical. He had time to kill, and they were in the process of this and getting through. And I don't know if he was in surgery that day, but it was coming quick. Goes to the library and starts checking out all these old books on, seizures and this, and finds that the way they treated this over the course of forever has been a ketogenic diet. Goes back and he's like, let's put off the frontal lobotomy for, a little bit of time. Let's try this. Puts him on a ketogenic diet, and the kid ends up like going into remission with no more. Deal. And he talked about it like a father's desire to save your child is powerful. And then he started this whole foundation. And like the fact that he did, I'm almost going to like tear up in this deal because I didn't realize years later would come back and I would be faced with the exact same thing where all of a sudden, my son goes into AK, he wakes up, he's blue, he lost weight. We check him in the hospital and find out his blood sugar's messed up, and I have no history of type 1 in my family, neither does my wife. But yet had worked with type 1. I had an athlete that was type 1 and had run into different people and didn't understand, like I knew they needed insulin. I know the role of insulin and I understood it from like this side of performance and carb cycling. But now all of a sudden you're in this where your body's not producing it and you're dependent upon exogenous and like had no concept. But I always go back to that Jim Abrams podcast we did all those years ago where he talked about like your responsibility as the parent and the father is to basically shepherd your child, through, and he deserves the same thing that everybody else does, which is a healthy life. And if the only resource you have is dependent upon doctors that are going to remove a part of your child's brain, like that's not good enough. You have to, take this thing and, mantle it and shoulder it. And so that has been, part of my wife and I's mission is to figure out like how do we create the best possible outcome for him in this situation. And if that requires us to micromanage every aspect of this thing and to do like the level of insanity probably that other parents aren't, I'm like I just don't know any other way.
John, and I want to tell you I'm very honored, but I very much respect you highlighting this on this podcast. Jim Abrams essentially was the trigger and initiating catalyst for that changing standard of care for patients' seizures. And more importantly than that, it made people aware of it. That's one of the biggest things. Like I completely switched, I walked away from some amazing, amazing opportunities in life to completely commit to this disease for a lot of the reasons you described. Because knowing and living with this and you just see the opportunity to do something and improve is kind of impossible to ignore. You see a patient and the struggle they endure. I mean, you feel it, every day is not perfect for me. And I have virtually every resource available to me and it's still not perfect. So patients don't have that. Some don't have access to all insulin, but that was the catalyst. And, John, passion and the opportunity to, leverage that to do something about it, I think is a really important. I mean, a lot of the major changes you see in the discussion around nutrition in type 1 have largely been patient initiated. It hasn't really, because you look at the literature like, okay, where's the data to support us moving to this next incremental spectrum? I mean, we're not talking like exponential changes. We're talking like, here's the next step. Here's the next step. It's slow growth. There's a reason for it. It de-risked research and other things, but we sit here currently today, and this is where I get really irritated, is we know that food, it's particularly carbohydrates, is the most potent factor in lifestyle and postprandial hyperglycemia, for sure. Like it's no debate here. Okay, that is what it is. And we have virtually no evidence right now to help give physicians the opportunity to feel comfortable going into a clinic when, let's say, your son's diagnosed and you walk in the clinic and they can offer some type of option, because the guidelines go back to the 1970s. The first ADA guidelines said 45% should be carbohydrates. Then it went up in the 1980s to 55 to 65%. Now it's at individualized because we now appreciate that almost all those guidelines, even USDA and otherwise, were based on general population recommendations. They were never
Yep.
for type 1. They were never because we had research to know what was the right choice. And we still lack that
Well,
today.
when we went through the initial consult, and I calculated it out based on body weight, I mean, they were recommending 60 to 70% of his, 300 grams of carbohydrate a day for a 5-year-old that weighs, 58 pounds. And I looked at the dude, I'm like, I don't eat 300 grams of carbohydrates in a week. And so the other one that was a extremely, like the pain of seeing this shit and wanting to help people, but then realizing not everybody is willing or ready to hear the information. So we took last time. I can't go to the endocrinologist appointments anymore. I just fucking I get too sideways with the doc and I start talking. And we went in and there was another parent that showed up with I think the kid was 4. She brought the little girl in a wagon because the girl can't walk because she was so heavy. The doctor said, feed her the diet that she wants to eat and just manage the insulin associated with it. What does that girl want to eat? Pasta, cereal, cookies, ice cream. So she eats all carbohydrates. The girl was so obese and her blood sugar, I think, was average something in the 300s. She was so heavy that the little girl couldn't walk. They brought her in a wagon. And I'm looking at this parent wheel this kid in a 4-year-old in a wagon who was literally sitting there like little Miss Muffet sat in her tuffet. And as we're going in, we come out and we see this. And then as we're sitting there kind of checking out, I can hear them talking. And I'm just like, holy shit, there's people that think this is okay, that your 4-year-old comes in a wagon because she has type 1. But as long as she's able to eat what she wants and mommy doesn't have to manage it, she just... How many carbs is in that? Great. Hit her with the insulin. Or maybe we don't hit her with the insulin. And I'm thinking to myself, what's this outcome? And more as a parent, isn't that child abuse? Isn't this, but it's standard of care, right? So I look at this and I think that this is a major failure by the parent. It's a major failure by the medical, but that's more typical than what we see on our side. And I don't know how to resonate this. I mean, but you also have to remember there's TV shows about people getting cut out of their houses because they're, 1,000 pounds and they can't walk, but yet somebody keeps bringing them the food, which is always my biggest thing. They go cut these people out and they have this, my 1,000-pound life. Those people can't get out of bed, but who's bringing them the food? And isn't that the person that's bringing it to them? Isn't that the abuser? It's I don't know where you sit politically, but every time I see Joe Biden walk up there, all I think is elderly abuse. I mean, he obviously is in the throes of dementia and has some, pretty serious medical conditions that don't necessitate a person who should be president or really just shouldn't be in a home. He looks like he needs to be sitting there with a warm blanket, and they keep pushing him up there on a myriad of probably mix of modafinil, Adderall, and whatever else they give him to pop him up there. And when I look at it, I think, I don't know where you sit politically, but I look at it and I think it's elderly abuse. If this was my father, I would not do this to him. I would not put him in this situation and have it look where this diminishes a legacy. And now he just looks like a fool in front of a lot of people. It's sad to me.
Well,
so
John,
so I mean, for the same reason that I see that, and I'm like, this isn't right. The mother bringing the kid in the wagon, to me, is not right. And I'm like, as individuals, as parents and as sons in this, when do we just stand up and be like, this is fucking bullshit? And more importantly, fuck you. I'm not going to, I was a rhetoric major in college. And, one of my favorite poems was, do not go gentle into that good night, Dylan Thomas. And I think about that shit constantly when I see it. I'm like, do not go gentle, rage against the dying of the light. This is a fucking problem. And the reason I do this podcast and I'm stoked that, we didn't prep any of this, that, you were recommended and I reached out because it's so near and dear, and to hear that, I'm not the only one that's bothered by this.
Well, I'll tell you, I think that there's a lot of people who are actually bothered by it. The obesity. So in type 1, to one of the points you brought up, in type 1 diabetes right now, this was a disease of underweight. This wasn't a disease of overweight. Most people who were diagnosed with type 1 diabetes were historically underweight.
Yeah.
And obviously the trends in the general population have gone up over time. There's a lot of factors involved in that. And, the food environment, the neurobiology of restriction, satiation, all these other things, right? It's a very complex situation, right? But we now see that those individuals with type 1 diabetes are now actually matching that of the general population. And people say, well, that's just matching. It's like, no. This was a patient population that was historically at or right slightly below weight.
Did the Greeks write about this, call it the sugar wasting disease? I remember reading in some Greek literature that they called it like sugar wasting disease, where people would die in a pool of their own sugary urine. And that was the Greeks 3,000 years ago writing about that.
Yeah, yep. There is, and actually that's how doctors used to diagnose type 1, is they actually, unfortunately, had to taste urine and see if it was sweet. That's also how they would find out. You could actually, there's stories of individuals urinating on the ground, letting it dry and seeing if ants migrated to it to see if that was actually because of the sugar, right? So there's a lot of, a very crude way to deal with the problem at that stage, but that's what was at least a reference to have happened at that time. And what do? You don't have like analysis tools. CGM is frankly very, very new in the grand schemes of this legacy of this disease. And most people didn't even know what this was. Like we were talking about a disease where most patients were diagnosed. I mean, their time clock was very short. We're not talking very long, very, very short. And we talked about, carbohydrate restriction a lot on this podcast already, but that was actually one of the few ways outside of fasting to extend the life of patients initially, because if you had a lot of carbohydrates, you would push people into DKA pretty quickly and you would exaggerate that impact. So, but I want to circle back to the issues of obesity, because that DCC and EDIC trial, the largest one ever done in type 1 diabetes, because it showed that tighter glycemic control through higher insulin load decreased long-term complications, it obviously highlighted that better glycemic control was important. And the ADA guidelines have become tighter and tighter and tighter as the evidence continues to show that, frankly, the higher you go, the worse you're going to get. So let's keep lowering it as much as we can. But when you get tighter glycemic control, usually, at least in that trial, was showing that the incidence of obesity in that cohort went from 1% at baseline to 31% of them were now obese by, I believe it was a 12-year follow-up. So that's a huge increase, okay? And so we know that a lot of these tools are all working to improve glycemic control. But as you start trying to play the game of, okay, I'm going to give more insulin to get tighter glycemic control, that also increases the incidence of hypo on a standard diet approach. So you get hypos. Now you're giving sugar, you correct the sugar, and you're just playing this game. So you're putting more in the system, you're giving more insulin, and obviously insulin being the most potent anabolic hormone of adipocytes, obviously that's going to drive issues. As insulin load goes higher, you're going to suspect to be gaining more and more weight just by the straight biology of insulin. So that's where we are. We also are confounded by the nature of what drives the general population to be on the trend it is with overweight and obesity. Over 60% citations go above 70% at this stage. It's clearly the trend across the board is it's going up. But that rate of exponential climb is way higher in type 1. And that's quite concerning, because something we were talking about before, but I didn't go too much into, is in type 2, obviously you have insulin resistance. But in type 1 over here, because the injection of insulin, so I have I use one of these Omnipod like closed loop. I've been trying it for
I've been meaning to hit you up on the pump. We've been so that's a little later discussion, but I was going to ask your opinion on the pump versus the needle. But yeah, continue to go.
Yeah, all right. So we'll definitely touch on that, because I only recently tried that because I used to do MDI for years. That's what I stuck with. But we'll circle back to that. But because it's going in here, I could inject it in my stomach. I could inject it into the back of my arm. I can inject it in my shoulders, try to get intramuscular. But when you do that, you're hypersaturating the periphery. So endogenously, John, you eat that. Let's say we go back to that story of 75 grams of a donut or whatever. Okay, you consume that right when it starts releasing the glucose. All that insulin is going to be released into the hepatic portal vein. So it's going straight to the liver. Okay, so if it's going straight to the liver eats up quite a bit of that insulin. So by the time it gets to peripheral circulation, the levels are much, much lower. The levels of insulin in type 1 diabetes are anywhere between 2.5 to 3 times higher. And so there's been studies where you take someone without type 1 diabetes and you give them IV peripheral infusion to match the same levels of insulin in the periphery, and they start getting insulin resistance within hours to days. Okay. So there's also insulin resistance in type 1 diabetes, which is not appreciated by many people. And that was discovered all the way back in 1928 by DeFranzo, showing that the equivalent levels of insulin resistance in type 1 compared to type 2 diabetes. And there's been a meta-analysis, I think 38 studies, at least as of 2020, And I don't think a single one of them showed the counter to this. So in type 1, people focus on glycemia because it is the number one predictor of cardiovascular disease. It is the thing that we can track every single day, and we know it associates with how we feel and the long-term acute and chronic complications. But when we talk about the number one cause of death in people with type 1 diabetes, it's cardiovascular disease. So we have to also consider insulin load. Okay, if you get higher and higher insulin loads, you're considering the BMI dynamics, the obesity trends we have, but you also have to consider that the insulin resistant factor, because we're at risk for higher levels of insulin resistance by default. So there's quite the level of balancing act that is in play here with type 1 diabetes, as far as the decisions, the treatment choices you can choose, why you do or don't do something, that are way more complex than what is happening in the general population, way more complex than many other situations. But type 1 is such a unique situation. If I remove myself from my own personal internal feeling as a patient with this disease and just look at it as a researcher, it's one of the most fascinating scenarios where you control almost everything except for glycemia and insulin resistance. And you can just hyper focus on the implications of that in disease. Frankly, it's one of the most fascinating model systems. It's basically a human insulin knockout model. It's fascinating, but the trends are such that there are now confounders, that a lot of patients, a third of them, are actually over 66% of them, I think 67% is the actual number now, are either overweight or obese in type 1 diabetes. And actually only about half of them are receiving guidance on how to exercise, and only half of them are receiving any type of nutritional advice. So that leaves, far be it people actually follow that guidance, right? They probably don't. But the question is, they're not getting this information either. And that was actually a paper that came out this year in 2023 looking at that by Fang, F-A-N-G et al. If anyone wants to look at that, Knowles of Internal Medicine. And those numbers aren't good, but they match up a lot with what we're seeing. And type 1 diabetes ain't going away. We're expected to double. Over 17 million people will live with this disease. Over a third of the people who actually should be living with this disease are not alive today because of complications, early death. And this is not an attempt to, scare anyone. It's just to highlight, for yourself, John, you and your wife going on this journey. I commend the hell out of you for what you have done to do everything you can as a parent to bring the best outcomes you know how to your son living with this disease. That's what it's all about. Like, that's what matters. And it also, I feel lucky to be here talking to you, but it could have been anyone, but just highlighting type 1 diabetes, because a lot of people treat it as the rounding error of the bigger diabetes. They don't focus on it as much, even though the day in and day out experience is much more comprehensive, much more, when you're making all these decisions, that you're taking one of the most fatal hormones. If you overdo it one time, that could be it. It's a tightrope, and it. And you go exercise one day, and that one unit you gave can now be acting like 3 units, and you're really trying to figure it out. And it doesn't, sometimes it's the opposite. And so you're really, really.
Or you put it in the muscle instead of the fat. That happens constantly. Like it goes in the muscle and it hits like this. You put it in the bicep in here. People don't even realize that the different injection sites have to have their own catalog, and being like, okay, if I'm going to put it in the glute, which is the biggest muscle, put it up high and don't get it in there. It's going to be slower if I put it in the bicep, if I do it in the shoulder, if I do it in the gut, where it is in the stomach. It is the most complex thing I've ever seen. And thank God my wife is, has an MBA and managed spreadsheets for BlackRock. So she manages everything. And then the other thing that we do, which I'm really surprised that the doctors don't recommend, is more frequent blood work. So we get blood work done, especially a bunch of micronutrient testing, which I've always done through my NFL career, just because the food that we eat is not as nutrient dense as it was. So a lot of the issues that we're running into, because the food just doesn't have what it needs to. So being able to supplement and figure out where he's micronutrient deficient and give him the best opportunities, which when I talked to the doctor, I might as well have been fucking talking about time travel. So wait a minute, you're getting his blood work to figure out where he's micronutrient deficient. That's not even something that's on our radar. But then I'm realizing that, most parents are thinking about I don't know. It just, so as an NFL player, you're going to laugh at this. When we would get hurt, the doctor would come evaluate us, and then they would go in the office and talk to the head coach. And then they would come out together and they would tell us their diagnosis. So that was how I dealt with doctors, to the point where I would just turn on my phone and record it. And then I would call and I'd get a second opinion, or I call a doc or somebody I knew and be like, hey, does this sound right? Because they just told me I don't need that bone to play football. I took a helmet to the shin, broke my fibula in half, and they said, oh, it's a non-weight bearing bone. You don't need that bone to play football. You should be able to play with a broken leg. And these are things. And so I have a natural mistrust of doctors. Just from the fact that as an NFL player, I got lied to so many times by things where I'm like, this doesn't sound right. And so not that I'm thinking that people are doing anything nefarious, well, they were in the NFL, but just that natural mistrust of like, okay, I hear what you're telling me. I should go research this myself. So at least I can have an intelligent conversation, and I shouldn't take anybody's word for anything. And, whether it be, COVID or, diabetes or cancer or whatever, we have a cancer charity that we started almost 11 years ago that raises money for neuroblastoma. So a friend of my wife's has twins. I have twins. One of the twins got neuroblastoma and ended up passing away at 18 months. So, we started a cancer charity and raised millions of dollars for neuroblastoma research in this over the last decade. And so having gone through all these clinical trials and talked to all these docs and gone back in this and realizing that the drug companies spend millions of dollars to develop a drug, it doesn't work. So then they pair it with another drug to see if this one works, and it doesn't, and that they have to constantly be trying to justify, the money they've spent, realizing like, hey, if the first two drugs didn't work, combining them in this other trial and giving these people the hope that it might work doesn't feel like a good outcome to me. So having been through this and now all of a sudden getting tackled with this thing, as I'm sitting there listening to the standard of care, which I know to be different than what I know from my own testing and all the other stuff. Yeah. Like when that guy was like, oh yeah, no, I mean, we don't even count insulin and protein in this whole thing, or protein and fat. Yeah. It's just all carbohydrates. And then he's recommending 300 grams of carbohydrates for a kid. And I'm like, I literally went out, Googled, found Bernstein's book and read it that day. And I was like, this feels like a better approach. At the end of the day, like at least I know protein is satiating. It can, maximize a lot of these things. And that felt like and the fact that Dr. Bernstein's in his 80s and is still alive and is probably like the longest living type 1 on the planet. That's a pretty good outcome for me, more so. So yeah, that's how we've gone down, but it's, it is so, as you've dealt with, and obviously I'm peripherally dealing with it, like the amount of micro decisions that you made. What did you say? 120 a day? It's at least that.
Everything, 180 to 300. Yeah.
Every food, weighing everything, knowing how much it is, and then being able to take into account the reason. You're like, man, we eat the majority of meals at home, and I know where I buy the steaks from. Like I buy it from a butcher or a rancher sends us stuff. Like Mike have micromanaged it down to the sourcing, because I know that like he doesn't react as well. The reactions are more favorable and less dynamic the more I can control where the food and how it's cooked and all these processes. But then, kids want to go out to dinner. They want to go out and see stuff. They don't want to eat every meal at home. So then you got to go out and find certain places, and, and now all of a sudden it's like, it's extremely like, as it's just, I had no concept of it until it tackles you. And then you're looking around and why is this not more of an issue? When I looked at the, wasn't necessarily an actuary, but very similar. I think if a kid is diagnosed at 10 and lives to be 50 over the course of that 40 years, the financial implications is in like the tens, if not hundreds of millions of dollars.
So so the cost is at least 2 times higher for medical expenses. But I've seen numbers north of $16,000 to $18,000 more per year for someone with type 1 diabetes managed disease. And that's not considering that, like, that's on average, right? We're not talking about someone who's really like the unique person really trying to dial everything in, trying to get every resource available, trying to get the best foods that they can possibly get, going all the way down to source, which is costing more money. Yeah. All these little things. If you can't get the prescription on time, then you might buy it out of pocket. Like these are things that, as
which we do all the time.
100%. Like I know, because I know how this goes. Yeah. I know when you get a new prescription, you're going to get said no 3 or 4 times. So by the time it actually goes through insurance, actually gets to the pharmacy, you're talking like a 3 or 4 week delay if you're lucky and you're pushing.
Yeah.
And then you got to have that doctor on your team who's really your advocate. It's, and then what do? You basically go without, or you pay out of pocket. And so, imagine not having those resources, and that's what you're dealing with. The implications are just so much different. Back to your key point about, one of my biggest goals I look, I'm in Santa Barbara. It's a ridiculously beautiful place. I feel super lucky. But I look up at the hill over here, and it's not really a hill, it's a mountain, but nonetheless, I look at the top of the mountain. I think, I know my goalpost up there is to change outcomes and patients. Like that's what I'm here to do. I'm not here to play around. Like that is exactly my goal, is to change that. But I know in order to do any of that, you have to ultimately change standard of care. Okay. So how do you change standard of care? We have to have the evidence to support that. And the only way to have the evidence to support that is to have trials that are convincing, that are these long-term randomized controlled trials to actually show these physicians and governing bodies, because they're making the decisions for what they recommend or don't based on the fact that they've had these other trials already done. We don't have these trials to actually say yes or no to this right now. So that's where we stand. Is you go in and the American Pediatric Society recommends against this approach in type 1 diabetes right now.
Yeah.
It came out this year.
Yep.
And
I'm well aware.
So if you look at that, and it was a review and also recommendations as a result of review. This is nothing against them, but I can tell you that was non-comprehensive of the evidence as well. We are actually in the process of a very long, grueling effort, but we have pulled every single study ever conducted on the impact of food in the context of type 1 diabetes and key biomarkers in type 1 diabetes. And we have some preliminary analysis. It's not complete yet, but when that's done, we will be able to provide across all studies what's been done. What are the impacts across the spectrum of carbohydrates? Because a lot of historical evidence on this has only looked in very tight, high or moderate carbohydrate intake. Like most patients with type 1 diabetes aren't really eating high carb, what they're recommended. They're actually eating more like moderate. They're actually restricting a bit to get into a lower carbohydrate range, which frankly kind of puts them into this Western diet, or the SAD diets, SAD American diet is what someone recently told me, which I thought was hilarious.
It is funny.
Yeah. And so, we see that if, like, let's say you don't have diabetes and you want to live on one end of the spectrum or the other, maybe there are some benefits over here on these super high carb approaches, but there's clearly.
What I've seen over the course of time, and there's not probably a definitive reason for it outside of maybe like energy expenditure, muscle, and activity level. But it's pretty well established that as we age, we lose the ability to process carbohydrate.
You're talking about like insulin resistance and glucose intolerance.
There was I can't remember the researcher. She was in Australia, wrote a really compelling piece, about like as we age, your ability to process carbohydrate and how it relates, whether it be muscle mass activity, aging effects and genetics. And then you go with, Dr. Michael Rose, who's down at UC Irvine, evolutionary biologist, who spoke in the Ancestral Health Symposium after I did and gave this fucking amazing talk on fruit flies, if you ever want to check that out. But he goes into this idea that, genetically within our gene signature at about the age 40, we have to return back to our ancestral diet, which looks a lot like a paleo diet, and that the American diet, standardized, promotes aging and this. And so he's given this whole talk, and then all of a sudden he drops something. And I realized I had to Google how old he was. And he was like in his 60s. I thought he was in his 30s. Which instantly I'm like, okay, if I see like a fit in shape person who's giving me I'm like, he probably knows what he's talking about if he's following his own, regimen. But that returning to an ancestral diet, and you look at like something like a paleo diet, which is always going to be high protein, hopefully not too crazy on the fat, but the carbohydrates are really coming from, let's say it'd be like sweet potatoes, roots, tubers, bulbs, and maybe some, fruit seasonally, and vegetables, which it puts you in pretty low carb diet because you're not eating extremely, calorically dense carbohydrate, packed foods like sitting down and eating a bag of chips or, whatever else you're eating. Like there's all of these factors that talk about it. And the fact that they're giving a one size fits all solution, type standard of care for kids, adults in here, and not looking at like, hey, like if your waist is bigger, then, like I think in the military, they do it like, they take your height, and if your waist is double more than your height, then you're obese, right? I forgot what that ratio is. It's like the 2-to-1 height to waist. There's no talk about this. Like if you're obese, there is a great case to be made that if you limit carbohydrates and even don't even eat them again, those people tend to lose weight and have a more favorable outcome. And I don't know why that's a hard discussion. And the only thing I can go back to is there is a weird emotional connection to food that I do not have.
Oh, for sure. Yeah.
I could give 2 fucks what I eat. And I don't mean that in a bad way. You bring up donuts. I'm not a donut person. I'm not really a sweets person. Like you brought up donuts. I'm like, I probably haven't had a donut in 20 years. And I drive by donut stuff and I hear people on social media and Instagram, like giving those homage to donuts. And I'm like, I'm not a donut guy. Yeah. Like I like steaks. I like more salty things. So I wonder if just my palate fits for that. But at the end of the day, like if I didn't, I do like fruit. I like the crunchiness of an apple for some reason. That gets me. And I like berries because I think they make me smarter. But like some of the things that I eat, and like when people talk about that, like, isn't that bland? I'm like, I'm not emotionally connected to food. Like I had a client years ago who, this was super random. So I got a lady approach me, very high net worth individual, asked me if I could work with her son. She admitted she was a terrible fucking mom. Didn't teach her kid how to cook and this. He was getting off to go to college, and she asked me, like, could you help him, teach him how to cook and, kind of do what I was never able to do as a shitty parent. And I was like, yeah, I'll help the kid. So kid comes in, big kid, super lunchy, like just like a lot of hyperinsulinemia. That look where like if you were to squeeze him, your fingers would kind of stay. You could see the fingerprints. And I use the term lunchy for that. It's just when I see hyperinsulinemia and I see people that like, they look fat, tight skin, like that look of where insulin's been high for a long time. Kid was 17 or 18. I recommend the mom, I'm like, go get his blood work done. I mean, I think the kid's fasted blood glucose was like 160. And ended up kind of sitting down and rapping with him a little bit. I'm like, you know anything about diabetes? Come to find out, his grandmother died from type 1 after they removed both legs, and he knew all this stuff. And he asked me, he's like, well, how do I, prevent this outcome? And I was like, well, we're going to get rid of carbohydrates, and, you need a high protein diet, and you're going to, really restrict. And we started talking about it. He's like, well, what are carbohydrates? We get deep into this talk. He stops me and goes, what about chocolate cake? I was like, what do you mean? He's like, chocolate cake. Like, am I never going to have chocolate cake again? I'm like, no, you probably never get fucking chocolate cake again. And he starts crying. All of a sudden gets all emotionally responsive in this. And he goes, my grandmother's made me a chocolate cake every single year of my life since I was born. It's this big deal. She comes over and makes this cake. I'm like, you mean the grandmother just passed away from diabetes? He goes, yeah, that's how we remember her. And I remember, like, when's your birthday? And I think this was like in September. And I asked the kid, I'm like, when's your birthday? Yeah, he's like, oh, it's in the summer. It's like in July. And I'm like, so wait a minute, you're crying and like tearing up and getting emotional about a chocolate cake that you're going to eat in 10 months. And I just run into these people that have such a fixation with like carbohydrates in this. I mean, think about like chocolate on Valentine's Day and, this, and how every holiday is based around these foods, and people have such a deep emotional connection. For me, I have no connection to food. Like, unless it's like a big steak with a big bone, I get kind of excited. But for the most part, like the emotional connection that people have, and this is the interesting piece because it's tied so deeply within our society from, everything that we see in this, like, hey, you got a promotion, a job, let's go out to dinner and let's do this, let's order this dessert. And it's so tied in. And now all of a sudden you're sitting there as a parent or having type 1 and you're micromanaging every ounce of this in terms of like, well, if I eat this, and I don't manage this properly, this could be the end of me. This could be a bad outcome. Either if I give myself too much and it drops me and I tank and I hit the bottom and I go into pass out, or I eat too much and I don't manage it and my blood sugar goes sky high and that creates terrible inflammation effects. So I mean, as a parent, I'm looking at that chocolate cake or every single thing, and then you can't but just then all of a sudden turn it on you, where I can micromanage for him, but I can't do it for myself. Like that's the part I can't get over, where like parents and like, this, I mean, like, yeah, we go out and we were at Mexican food and my kids wanted to eat chips. I mean, my daughters are super fit and they work out so they can have chips, but then my son feels sad that he doesn't get chips. And I'm like, well, I didn't eat chips. Mommy didn't get chips. We're fine. It's such an interesting thing. And I almost wonder, and I don't wish this on anybody. I wish everybody had to micromanage a type 1 as almost the like test drive for your body in your own life. Like you manage this type 1 for 1 week, and let me see if you ever look at food the same way.
I suspect most people won't. I mean, you'd gain insights that I think most people will never appreciate in their entire life. I was obese as a kid. So I was an adolescent obese kid. And I remember trying damn near everything for 5 years and failed numerous times. Usually this is because as a kid, I'm just jumping over the ledge trying to do the next extreme thing to figure out like what's going to be that solution. I didn't have, my family was active. My dad's run a marathon. My uncles ran, I don't know, over 20 and climbed mountains. Like we're around a very active family. That wasn't it. It was just over time, it just accumulated. I still remember looking at photos of myself. And this is pre-diagnosis of type 1, by the way, is just looking at myself over time and seeing it creep up over and over. And I just look at pictures of myself early on, and my self-esteem was not where I hoped it would be. That's for damn sure. And especially at that age in school, superficial looks are quite more important on a lot of people and how they feel about themselves. And so it had a lasting impression. But having some accountability is what ultimately changed that. About 5 years of trying everything and failing. I mean, frankly, I didn't try everything, but I'd never stopped trying. But you just keep falling off the bandwagon. I tried this. 2 weeks in of running every single day, I feel like shit. Now, I wouldn't recommend that for someone to be their way of losing weight now, but at that time, that's what I was trying to do, and it was just failing. So I deeply appreciate on a personal level the struggle with trying to regulate being overweight and obese. And my parents were super supportive, of trying to regulate that. It wasn't that. It was, I needed some frequent accountability and a level of internal motivation that there was no way I was going back. And I finally got to that point. And so I finally lost the weight. I actually plateaued at that weight. I think I came down like 50 pounds as a kid. And then a year later, completely irrelevant to that weight loss, I got type 1 diabetes. And so like for me, my journey was being obese, struggling in every single way to do it, realizing that exercise and nutrition was the solution out of the problem. And it wasn't for free. It took dedication and long-term commitment to it. And then I get diagnosed with type 1. This is when I became married to the idea of how important lifestyle can be in regulating not only like health in the context of me being obese, but now my disease. Yes. And I could tell you on a personal level, all I wanted to do as a kid was when I started losing weight and started to change my physique was like, I want to be big as strong as fast as possible. I don't care what it takes. This is it. This is what I want to do at all costs, John, at all costs. That's what I wanted. And I was willing to do quite a bit. I had some people actually reach out to me and talk me at the ledge. Like I was 18 years old, and in full transparency, I have nothing really to hold back. I reached out to a well-known bodybuilding coach, and I said, "Hey, man, like I'm ready to take the plunge. I want to start like taking steroids, because that's a quicker way to get to this goal. Like, because that's what I want. I'm in the gym 2 hours every day. It wasn't optimal. I was doing everything right, and." Long story short, he forwards it to someone else. That person calls me, and I'm a kid. What are they doing, wasting their time trying to help this idiot? And either way, they get on the phone with me like, all right, pause here.
Slow down, Tiger.
Give this a break, okay? Like, I know you want those things. I resonate. It was actually a professional athlete with type 1 diabetes.
Oh,
and that person stopped me and said, don't do that. Well, they didn't tell me don't do it. They said, look, if you're absolutely going to do it, this is what testosterone will do. This is what GH will do. This is what these things are going to do. Like, if you're going to have to do it on your type 1 diabetes, but I really don't recommend it. And here's why I don't recommend. Thankfully, I didn't at that time because, I don't know if I ever would have went back, being bigger, stronger, faster, I'm sure, either way. So side story on that note, but I resonate very deeply with wanting that. But I also, when I got type 1 diabetes, it was so clear to me, as you mentioned, having someone manage someone with type 1 diabetes, it was so clear to me how direct the impact. I remember walking out of the gym and how I would directly dose insulin. Because at this time I wasn't low carb. So I was directly dosing insulin. I could just see myself
Yeah.
like filling up afterwards.
Dude, well, I mean, in 80s, 90s bodybuilding, I mean, you saw Arnold Schwarzenegger, and then all of a sudden you see like Dorian Yates and those guys. I mean, that was they started using insulin, they started using GH and IGF-1 and all these other kind of insulinogenic kind of related compounds. But it was really, that's why, I mean, a bunch of these bodybuilders are dying now. And the reason is because they're like, just side note, when my son got diagnosed, I was fascinated by so the way I know insulin to work is very different than a type 1, the way it works. But there was a bodybuilding forum that you can pay to go on and join this guy's site. And one of the guys that worked for me had access. So I jumped in, and all these pro bodybuilders were in there talking about their drug cycles. Yeah. And they were more importantly, talking about how they were using insulin. Mm-hmm. And I could not even fathom how they were using insulin. They were using like long-acting insulin to keep their insulin constant because they felt that if they could keep their insulin under 90, anything that they ate would not be put on as fat. They could put on all muscle. Then what they were doing is they were dosing like 30 IUs of insulin, fast-acting, before a workout, and then consuming like carbohydrate, kind of heavy, kind of protein-ish drink, like peri-nutrition, and then hitting 30 IUs of Humalog after, taking a shake that had like 1,000 calories, and then consuming a meal after, and like trying to balance the whole thing. But I remember the guy posting a picture of like, I think it was like a chest workout or something, pre and post, before he had done, and the pump that he got from insulin, it looked like his skin was going to rip off. Like it looked like he gained 10 pounds during the workout. That insulin, and he was talking about like the Slin pumps or the insulin pumps. And he's like, you can go in and do all the bodybuilding you want and all this, and you'll get a pump. But if insulin is in the system and you're able to manage it pre and post, like the effect was like, I've never seen it. It looked like somebody inflated these guys with balloons. So when you see like the Sam Suliks and all these guys on the internet with these sick fucking pumps, it's from either IGF-1 or insulin or these effects. But I could not even extrapolate what these guys were doing in terms of like the way that I manage it for a type 1. And I wanted to almost reach out to these guys and be like, first of all, how are you not fucking dead? 2, how have you guys not just like, I mean, with that amount of, 60, as you know, if you were to take 60 IUs of Humalog and have something like Levemir or Lantus in the system that you're hitting that in the morning and night, not wearing a CGM, so you could go to sleep and tank and just never wake up again.
Yeah, I'll just tell you, John, one of those I use. Yeah. One of those I use would drop me anywhere between 50 and 100 points right now. Like right now, if I were to do this, it'd be over.
Well, because you are, obviously low body fat, you carry, a high amount of muscle, your physicality is high. So your body's extremely insulin sensitive. It's like my son, like a very small amount is human, but these dudes are jacked and they're taking 60 IUs in a day. I'm like,
oh yeah. That's like, that to me is, the ironic part is, yes, you are. So they're basically taking advantage. I don't think they actually know. I think they think, okay, this is anabolic. That's why it's helping me. But the reality is that you're hypersaturating the muscle tissue. When you inject it, just like obviously for type 1, you inject in the periphery, you're hypersaturating the peripheral tissue versus the liver at 3-to-1 ratio now, compared to the opposite effect if it goes endogenous, right?
Yeah.
So yeah, there is that potential that you are doing that. In fact, one great example of this is when I'm not recommending this. Okay, there's not a recommendation.
No, right? I'm not recommending any of this stuff. But also, I was going to joke with you. When I started lifting weights, the reason I started lifting weights at 14 was my brothers were all big and strong, like they all played college football. I was super skinny and had like a pencil neck. And my brother, I don't have a pencil sitting here, but he would constantly like take an orange and put it on the pencil and be like, "This is your head," and then he like try to break the pencil. So I wanted to be big and strong. And it was my entire goal. And I was just so fortunate that I was like, when I was 14, I was 6 foot, like 155, 160 pounds. I started lifting weights, and the next year I was like 200. And every year I put on 30 to 40 pounds and grew 2 inches. And then when I was senior in high school, I was like 6'4", maybe 245, 250. Yeah. I went to college and I grew 2 more inches. Now I'm like 6'6", and I ended up, being 23 at 300 plus pounds, benched 500 pounds and was big and strong. So from the time I was 14 to 22, I put on I doubled my body weight. I went from like 155 to like 310, 305. Grew from 6 foot to 6'6". and, benched 135 my first day and, benched 535 for a triple when I was in the NFL and got to play for a decade in the NFL. So like my goal was to always be big and strong. I was just really lucky that every time I went into the gym, but I made a ton of mistakes. So with my company, Power Athlete, I offer training programs. And really what they are is a lighthouse to show you all the ways I fucked up and how to avoid it all. Right. And I wish that like I had this instead of us looking at, just figuring out whatever the fuck to do. But so that's kind of the basis. But when you brought that up about wanting to be big and strong, I know exactly what you mean. And I can't imagine if it didn't happen the way in which it did, how desperate I would have felt.
Well, let me tell you something, John. When I first went in the gym, I was barely squeezing out 135. So I wish I walked in and started cranking out 315. Trust me. But it was interesting, back to the point about like insulin and its impact, is like, I remember right after I got diagnosed, I went down to sub 200, and I'm 6'5". So I was sub 200, and I'd always been like 220, 240 after I had lost all the weight. And when I started injecting insulin, it was like, I put on like 30 pounds, like almost immediately. And it wasn't like a bunch of fat weight either. Some of that's probably water weight, obviously, but it was real quick, real quick when I put on that weight. And obviously some of it was fat, but still a lot of it's water weight. But either way, I put on weight real fast. And so when people do these things, the irony is that, and we talked about some of these prior studies that show that insulin is way more anabolic to the adipose tissue. Yeah. So when they say, it's not going to affect your adipose tissue, that's a little hilarious, because it is certainly doing that. Maybe the other things they're doing are like counteracting some of that effect. But yeah, when you start playing, I'm very grateful, one, that person took the time to walk me away from that, and two, for them to, for me to kind of do everything but that to try it out. And so, either way, insulin is very powerful, and there are a lot of, for anyone listening who's thinking, oh man, like that's what happened to them, you gain that much. Also, don't
fucking do it.
Yeah, it is so dangerous. It is not a simple thing. It is so dangerous. It can kill you if you don't know what you're doing. So just so everyone's aware of that. But yeah, man, it's like I still remember when I used to, and the timing of this is how like to the gram of everything I used to be. I literally counted every single gram of protein, fat, carbohydrates, every single meal. When I go into a workout, I would time it just so that I knew that peak insulin would happen right when I walked into the gym. And I could change my lifts 20%. And there's not exaggeration. Like,
I believe you.
It was that predictable.
So when I did the anabolic diet with Morrow, he had me basically, I ate zero carbohydrate. It was a high protein, kind of moderate fat. I think I was eating like 450 grams of protein a day. I've long suggested that there is no upper limit and no problem with consuming as much carbohydrate as you want. Protein. And, like I figured, hey, I'm lifting weights, I'm training, I'm sleeping. So I didn't eat a carb for like 21 days. And then finally, he was like, hey, I want you to like get up in the morning, work out. I want you to fast all day. And then that night, I want you to go out and find like an Italian restaurant. I want you to sit down and order some pizza and some pasta and fucking go to town. So I'm like, well, how much? And he's like, you'll know. So I was living in Philadelphia. I walked down the street to this Italian joint. I sat down and I was like, I'll get this pasta with meat sauce and this. And he's like, I don't want you to eat any fat. So try to like eat, or it was like a chicken, but he's like, no creams, nothing, just red sauce chicken, like real, like high protein, no fat, all carb. I'm like, all right. So I get some red wine. I start eating pasta. And I was like, just bring me like a triple portion, right? It was like a pound of pasta and a chicken breast. And I start eating. And all of a sudden, like there was a thermogenic effect and I start sweating, like dripping sweat into the food as I'm eating. And the lady comes over and thought I was having a heart attack. She's like, yeah, right. I'm like, no, everything's fine. The food's great. So I order a pizza. I proceeded to eat easily 2 or 3 pounds of pasta, this chicken breast and this massive pizza and drink wine. And I sweated through my clothes so bad that I thought I was like, it was the weirdest feeling. I went home, had a great night's sleep. I woke up that morning. And when I looked in the mirror, I could see a vein in my ab. I was so lean.
Yeah.
It was the weirdest effect. And I completely like I was typical 23-year-old kid. I was probably, NFL players, 20% body fat. I mean, I ended up 2 years later at over 300 pounds at sub 10% body fat. I was the only guy that they'd ever tested in the bod pod that was under 10% over 300. I was at like 7.88%. And I used this carb cycling. And I was like, dude, when I restrict carbs and I put them back and I'm smart and I know how to do this, like I can get as big and strong as I want. And that's when I realized the power of insulin.
Yeah, you can, and I can even see that. Like, I definitely think it is insulin, not necessarily carbohydrates, because there's been things that have caused elevations in hyperglycemias for me that were unexpected. And then taking the insulin, and that insulin effect, independent of me even eating, is what's really facilitating that. Like, one great example of that is personally taking dexamethasone? I forget. It's dexamethasone is a corticosteroid.
There you go. It reduces inflammation. They do it in iontophoresis. Is like, where they soak dexamethasone into like, using electricity. They soak it in and can use it for reducing inflammation in tendons. That's how I know it is.
Yeah. And I was taking that for, I forget what issue it was because I went out and biked, completely fasted for over 24 hours. And I was in Tampa, Florida at this time. And the dead of like one of the hottest days of that year, I was super, like, really dehydrated, and I get on the bike and I put the music on and I cranked out a all-time PR, and I was so jacked and pumped on it, like not jacked, like physically, obviously I just fasted and I did a cycle ride, and like a full out sprint, and I felt amazing. And then, but I had music blasting in my ear and all this other stuff. And I get home and I couldn't hear out of my right ear. And I'm like, oh man, my wife's a speech pathologist. So I'm like, I can't hear out of my right ear. And she's like, and all these other factors, like obviously come to find out dehydration and the extreme exercise, obviously blasting my ear on top of that didn't help. And so long story short, she's like, you need to go to the doctor now. And because this could play out and it might not fully recover. So either way, I begrudgingly went, and she was right, got on dexamethasone, and not that I wanted to, but either way.
Were they doing it like injectable, or were they like a pill, or because usually it's like a cortisone?
Yeah, no, they did pill. They offered injectables. The price difference was like, whatever, I'll suck this up for, 2 weeks or whatever, because the price difference was astronomical. But either way, so I took the oral form, did the whole protocol. And during that time, you become super insulin resistant, right? So you can take way higher levels of insulin. And I still remember how much, I won't tell anyone on here because they may go do this stuff, but I was taking so much more insulin. I remember when I was going to work out doing this. First, I fixed the whole ear problem, so it definitely helped. I'm glad for that. And it was a short bout of insulin resistance that whatever, move past it and move on. But all that extra insulin, I'd go to work out, and my God, I would sweat puddles. And I didn't change my diet. Like, keep in mind, I'm still very low carbohydrate. I'm consuming less than 50 grams of carbohydrates a day. I didn't all of a sudden start eating more carbs. It was because I was so resistant. I was taking so much more insulin. I was consuming so much more water that when I would go to work out, it was just so different. And obviously, when you do this and you have water in the muscle, a lot of that is what that is for, like you describe that bodybuilder and yourself, who just like you can see an ab in your muscle. Obviously, you start expanding the glycogen and water stored in the muscle. It gets massive, and your skin looks so thin comparatively. As someone who's into lifting weights and all these other things, it gets real addicting, right? Like, this is nice.
You're like, finally, I look the way I look without good backlighting,
Yeah. I didn't need that help with that little twist of the camera. Yeah. And I remember and also the water, the leverages the muscle, right? Like some people's tie-ins are different and all these other things that lead someone to be superior versus not superior. But either way, like having that additional water in the muscle larger and the leverages that benefit, you get stronger. But either way, I can definitely resonate with that experience of how, and in type 1, again, it gets back to that. It's like how powerful it can truly be with these molecules. I mean, you are really changing your physiology, metabolism so powerfully. But nowadays for me, as a researcher and a dad, and my priority is not like to be the biggest, strongest, fastest, just be like the most functional, fit person I can. I want to be the strongest I can be. I want to be the fittest. I want to be able to go as far as I can, as fast as I can in endurance or anaerobic bouts. But I just show up every single day. I'm not playing the, very, very high insulin game that I used to play when I was younger. It makes things a lot tighter, a lot easier to control. And I found that if I just show up consistently and do it, there are probably some benefits to having some of that on board, but it's not necessarily, for me personally, worth the other things you have to deal with, like the uncertainty, the unpredictable nature, and all these other factors that go into, especially like right before exercise. There's a lot of guidelines out there about what you should or shouldn't do in type 1 diabetes, but as you probably appreciate, if I were to say, hey, this is what I do, and here's what your son does, I bet they aren't, we both probably, we're doing very low carb, right? But like, we aren't probably doing the same thing right before exercise. There's probably some spectrums of overlap and similarities, but there's clear differences, right? And everyone has to understand that and appreciate that. So the standard guidelines in type 1 diabetes are probably good points to just like, for some, especially if they are doing a high carb approach, just to look at and say, okay, here's some general things you should do, and here's why. And they can start looking at it and say, okay, that is happening to me, but man, I'm dropping twice as much, or these other things, right? So it just starts, a lot of this stuff just gives people a place to start. Now, beyond that, it's really up to any individual to really refine it for themselves. Here's a foundation of all the toolkits on how to do insert the blank. It could be anything, any diet strategy, any insulin strategy, whatever. Here's how that works. Here's how it typically works. But at the end of the day, a tremendous amount of that work is finding out how it works for you. Because I can promise you, as you talked about already, that one size fits all is just not a thing in type 1. And frankly, it's not really a thing in a lot of people. But there's some foundations and principles that apply.
It's not a thing in health. And I also am not a crazy person, and realize that when you're trying to make health recommendations and trying to manage 330 million people of different ethnic backgrounds and different socioeconomics and this, I mean, like, how do you create a one size fits all, or at least like, the common denominator? I remember years ago, I got approached about doing a corporate wellness program, but it was really a corporate performance program for a CEO that wanted to make all of his, C-suite fucking badass. So we implemented this program. And then, so I had no idea about corporate wellness. So I figured like training programs, we went out, we spec'd, this guy was willing to spend money. So we spec'd and built him a custom gym, and all of his guys were on training programs and assessments. And these dudes wanted to train like professional athletes. And then he was like, hey, to write this thing off, we got to extend it to the company. And I was like, oh, great. You want to bring this out? And then when I dug into what really corporate wellness is, it's an email once a week for people to walk for 5 minutes, to not sit down. I mean, it was really low hanging fruit. And I remember like what I thought versus here.
Yeah.
And, when you're talking about trying to manage the health of a whole lot of people who, we're, getting wrapped up in, viral challenges, eating Tide Pods, and, people that, have like no concept of what I like to say, which is like, they're the same people that, you got to have a warning label on everything. Like there's a warning label on gasoline, don't drink it. And you're like, well, shit. I mean, like, I don't know if this, we become dumbed down in society, but like you would think that people would use performance as some form of measure, as like almost like a starter's guide for their body. Like if something's chasing me and I can't run fast enough or run long enough to survive, like that should be a good indicator. And maybe it was for a long time, but we don't live in those times anymore. So we're still with this, archaic software and hardware, and, it's been evolved for millions of years. And we're living in a world that, is far beyond what our original software and hardware is. And people just have no concept of it. I mean, and then, you factor in super hyper palatable foods and, lack of nutrient density and this, and it's, a lot easier to send somebody out and have them, get $1.99 McDonald's than to go figure out all these other stuff. I mean, we've created such ease and access of food, but yet it's not doing anything to help us as individuals. And then you're paying into a system that's, I had the same conversation with the cancer deal. It's dramatically more lucrative to treat cancer than it is to cure cancer. I mean, and whether or not people are like, oh, that's conspiracy theory. I'm like, no, that's economics. If you look at what these treatments cost and this whole thing, I mean, this is a multi-trillion dollar business of trying to manage cancer. And, there's really no, people are like, oh, there's no cure. It's like, how do these treatments work? And it's ugly to the point where you just hope to God you don't ever get it. Because, once you get into the machine of cancer, like, type 1 and all these we do in this country an incredible job on acute things. Like you have a heart attack, they can save you. You get a gunshot wound, you save you. You get in a car accident, you're fucked up, the hospitals will save you. what we failed in this country is in terms of these chronic kind of like managed care diseases and problems that take, we're just not good at managing it. Diabetes obviously being the first one, cancer and some of these other things. It's just, it's an ugly thing. And the only thing that you can do as an individual is take your health personally and say, like I said, do not go gentle. I as the individual have to be the captain of my own ship. Nobody's coming to save me. There isn't any doctor who's going to be out there who's going to, come out and lift the weights and do these things. As you know, you go to the doctor, it's a lot easier for them to prescribe a pill than it's like, we can give you a pill or you can lose 20 pounds. We'll give you the pill because people aren't going to lose 20 pounds. And that's a scary realization.
Yeah, and one way to potentially fix that is actually, when you go to medical school, right, you're literally inundated with more information you can possibly put in your brain. It's more than they can consume, but you just try and learn as much as you possibly can. And so nutrition is not a core component of that process. And actually interesting, when I was at University of South Florida in their college of medicine there, a lot of students actually reached out to find extracurricular opportunities to get guidance on that because they themselves had appreciated that journey and wanted to have more information. But yeah, until they're actually on the boards and you're actually tested on it, will it likely not become a central part of the theme of medicine, even though frankly, exercise and nutrition, no one's going to argue, is the foundation of making these changes you're referring to. Yeah. They are the first point of care. And not like controversial. It's not like, okay, this is like conspiracy. Like this is the first point of care and it's acknowledged to do that. The problem is that it is incredibly difficult to do that in the system as it's currently set up, right? So how do you get someone with the nutritional advice? Like clearly you can't sit down for 15 minutes and say, unless they follow 2AT exactly what is done, which is frankly probably not going to happen. They have questions like, what do I do here? As you mentioned, like, hey, you're not eating carbs. And they say, clarifying question, cake. It's like, well, no, cake's carb. Like usually cake's carb unless you're using almond flour or some other type of ingredient.
Yeah, but then it's still going to have it. You could make it like zero carb, but it's also zero fun, as you know.
Now, John, I'll challenge you on that one. You can make some good recipes.
We have this super high end lady. There's a place here in Austin that it's gluten free, sugar free. She has all this. It's pretty amazing. But it's also like a cake is going to cost me $40, right? So we get that cake like for the kid's birthday, like we'll do it.
Hey, John, let me challenge you. Maybe I challenge you to cook it. What if you cooked it, John? What you got to get some almond flour? We have stevia. Okay.
We've done it, and I realize for things like this, there are people that are artists. And I am more than happy to find like this lady's a wizard. This lady's a 99 level wizard. It's like going to some of these barbecue joints or steakhouse where you're like, okay, I could do this at home, but this people are really good. But yeah, so we got this cake. It's like $40. I went and picked it up, and it also weighs 50 pounds because it's all almond flour. You're like, God damn, these things are heavy. One slice is this big, and you're full for a month. But it's man, this is such an interesting, and I'm so stoked that you got a chance to get on the podcast with me and talk through this, because I sometimes feel like I'm living in this weird bubble of crazy people where you don't really have anybody to vent to, and my wife and I just vent back and forth, and it's not something that very many people ever deal with, and it's just. And then when you do deal with people, they don't look at it the same way you do. And then when you get online and you try to find like-minded people, they kind of look like crazy people. And so there's this,
John, it is and that'll always be the case. That's always been the case in nutrition. It's frankly way more amplified in the type 1 diabetes community because as you appreciate the passion in it is probably, I don't know, I would challenge anyone to match the passion in the type 1 diabetes community with any other community. It's unreal. I remember when there was a New York Times article about that pediatric paper we spoke about before in 2018. That New York Times, Connor was the last name of the author on that. It was the most emailed article for New York Times in 2018. It is to appreciate how powerful and the advocacy of this community is kind of hard. It's hard to actually put a pulse to. It's so powerful. But yeah, there's a tremendous amount of passion, but it's for good reason. Those people know what it's like every single day. The parents who are managing their kids know what it feels like to be up all night and to manage the highs and lows.
Yeah.
And it's and probably wishing it was them and not their kid. And then you have
I've told my son a million times, if I could take this for you, I would. I could do it. I mean, I would gladly die on the sword every day. Like I like, you know, I mean, I tell him, I'm like, dude, we're going to find like, do not give up hope. Like if we can put people onto Mars, like, I don't know why we can't solve this problem. And I think there's smart people working in this direction. But I tell them all the time, I'm like, I would take this for you. And I'm just not saying that lightly. I would spend every dollar I had. If you said, hey, you have to sell everything and bankrupt yourself and you could cure it and fix it. I'm like, great, we'll fix him. And then we'll figure out the next part. Like that's just because, and you've lived with it, but it's like, I'm not okay with this being the final outcome. I don't want like, if you have to manage it, you got to fucking do it. I mean, this is what you do. Like I'm always amazed by people that give up. I'm like, I don't fucking give up on anything, like to the point of almost stupidity and detriment. But I'm like, we're not giving up because there's no other solution. Like you either have to do this and this, but I'm like, if there's a solution, we'll find it. And if it's not, we'll just manage it forever. But if I could take it, I'm like, dude, I would gladly take this just for the fact that like, if it's me and I'm in the fight, then I know I got to fight. But trying to fight for somebody else is almost more exhausting. It's probably why I don't like watching football. You know, I liked playing football, watching it. I'm like, I want to be in the fight. So it's, but it's, injectable or Omnipod? Because the new one popped up actually has glucagon and different types of insulin, and it's all kind of, I mean, we got into all the AIs and it just looked overwhelming. So
I'll give you like a quick overview and of these two things. So I did MDI for years, for a very long period of time. I had tried a pump for a short period of time. I didn't really like it because I felt like the rapid acting insulins, especially around exercise, just really cranked you down. So you had to really prepare ahead of time before exercise. You couldn't just like go and do it. So using our insulin and like Levemir or even longer acting basals was so stable on exercise. I really enjoyed that, and I didn't like having somebody attached to me all the time, especially through tubing. But I would look at the literature on hybrid closed loop technology and thought, this is interesting. It doesn't move people on average into all the recommended metrics, but it helps people. All these tools, CGMs, pumps, on average, you just give it to people, they do a little bit better. Okay, just a little bit better, not markedly better. It doesn't put all the people below 7% HbA1c, which again is just the standard of care guidelines, not necessarily what is normal, anymore. But it still doesn't do that on average. And what's amazing about those tools is that if you actually look at their continuous graphs over a lot of these studies are 6, 12 months, and you look at these tools, what you find is that almost all the benefits are outside of the feeding windows. Okay. So if you actually look at the mean glucose curves and look at the time and range, look at those for those studies. Okay. The New England Journal of Medicine papers, Brown, Burnside, Toscherman, I think is the author. The bionic pancreas. Look at all those studies that came out in the last 4 or 5 years and look at their curves. What you'll see is that from about midnight to 7 a.m. is where all the benefits come from. During the day, it's not meaningfully different. Okay. So almost all that's coming outside the feeding windows. So what that suggests is that food is overwhelming the system and not allowing it to be that effective. So I know of some individuals who have considered low carbon and hybrid closed loop. And I'm saying, it sure would be nice to not have to think about some of this as much and let this run the show if it can. So when I said, okay, I posted about this plenty of times about they don't push people in the target ranges. This is the next generation technology. I talk about that because I think we should be doing better, period. And so, but what is that if I don't try it? So I did. I got an Omnipod Dash with a Dexcom, and I use Open APS. The reason I do that is because it allows you to set the target range wherever you want. The current technologies that are FDA approved only allow people to go to a low range of typically somewhere like 110 to 120. So your lowest range is in there. So I wasn't really super jazzed about doing that. So I went the packed route allowed me to set my own targets. And actually, what I did is I had a friend help me. And he's a researcher as well who actually works on AI and technology because it was overwhelming for me too.
Yeah.
Like there is a literal book
Yeah.
on how to actually set this up. And I'm thinking, man, where's the time for this? So for one day, over a 3-hour period, I asked some friends a bunch of times who had done it, like trying to get information. One day I sat down, he spent Sunday with me for 2.5, 3 hours. I got all the supplies and he said, here we go. Set it up, did this, I put everything together, the website together and got it all ready. And he said to me, he said, Andrew, don't bolus. And I said, I'm like, oh, I'm gonna listen to that. Like, obviously, I'm gonna bolus. I'm gonna do, he's like, no, don't bolus. We're gonna set auto bolus and let it run the show for you and see what happens. Just try it. And I said, nah, like I know what I'm doing. It's all patients with type 1 feel like I know what I'm doing. Don't tell me what to do. But out of just pure respect for this person, amazing human being, truly one of a gift to type 1 diabetes, truly. I said, okay, I'll do it. Man, if it wasn't 5 days in, and this sucker was, I didn't touch a thing, and it was doing everything for me. Now, the one thing I quickly realized day 3 in is exercise no go. You have to prepare yourself prior to exercise, unless you just want to start downing a bunch of Smarties or gummy bears or whatever.
Yeah.
But it was literally auto bolusing. I've been on it for over 3 months now. It literally has auto bolused 99% of my meals. I haven't even pre-bolused almost any of them. And my last HbA1c was 5.5.
Wow.
And I did that on purpose. I did it on purpose because in my mean glucose, I think it was 105 over that period. Standard deviation was 20. And what it taught me was I wanted to get a real go. I can say whatever I want, but if I don't try it myself, what does that say? So I gave it a real go. I let it auto bolus everything. I had to regulate pre-exercise. That was something I had to do.
So did you have to inject pre-exercise, or did you adjust it on the
actually have to shut it?
Unit?
So I actually have 2 settings for myself personally. When I go into exercise, it depends on the time of day. The morning I can get away with it not dropping as much depending on what I'm doing. And as you know, type, duration, intensity of the exercise all play a role. So what I found is
like aerobic pathways crush it, lifting weights and training end up spiking it. So it's kind of an interesting thing with like what I think it's a pathway thing. Like if you're acting like a more anaerobic, it's gonna aerobic.
So that's correct. On average, it is the case for people. But what I used to do, so these are the tools and tricks kind of come in is, so with this, I found that if it's in the morning, I can get away with most types of exercise and it handles it pretty good. Now, if I do intense cardio for prolonged periods of time, over 30 minutes, what I do is I reset my category to where the amount it will bolus to try to autocorrect going up or down is diminished dramatically. And if I fast all day and I go into an evening aerobic exercise, I will have to shut off all insulin 30 to 45 minutes before and keep it off the entire time, or I will tank in the afternoon if I fast up until that point. The one correction for that is if I eat a high protein with some level of fat in it right before exercise, then I can leave it on autopilot the entire time and it'll run the show because of that protein's offsetting that dip to the same degree, right? You have this dip and you have the proteins kind of working to match those two effects. And that works like gold a lot of times. But the exercise is, because it's rapid acting insulin now, you're not playing with these longer acting insulins. And we know that the kinetics of the insulin do play into your body's response to the exercise. Okay, like how much are you oxidizing carbs versus fat? It clearly has an effect. There's not a ton of research on this, but there's some that indicates that longer acting insulins kind of set your metabolic state in a more stable situation, although some would argue that's maybe not as good. And then whereas the more rapid acting insulins model typical physiology and allow you to kind of flux in and out of certain type of substrates, either way, regardless of that point, I find that with these rapid acting insulins, 90% of the day, well, maybe 80% of the day, depending on how long the workout is it's stable. And it does all the work for you. Now, if you really want just like because it'll start going up and you can do little tricks and tools like, okay, I'm about to eat this. I'm going to go for a 5 to 10 minute walk about 15 to 20 minutes afterwards. It's going to increase the absorption rate. Like there's all these little things you can do if you really want to do it.
Yeah.
Or you can pre-bolus. You can still do a subtle amount of R on top of it. But you have to keep in mind that a lot of these tools, specifically the one I'm using, it's learning as it goes. So the more you put into the system to try to overcome it, the less it's a learning. And so the balance I've struck with it is it depends on the time of day and the meal and what I'm doing. But if I go eat, like what you said, a ribeye, like if I go just eat a massive ribeye, which is wonderful. Me and you might be the same on respect.
Yeah. I'm in.
Well, if we ever have a chance to link up, we'll definitely do that. But if
you're ever in Austin, I used to live in California. I grew up in Palos Verdes and then lived in Newport Beach. So I'm well familiar with Santa Barbara in that area. Yeah. So, but we moved to Austin in 16, 17. So been out here for a while.
Yeah. It's, we've only been out here for a little over 6 months, and it is absolutely beautiful. It is ridiculous.
Last year, was it last year? No, it was last year. I got invited to go for Indian motorcycles and ride flew into San Francisco, and we jumped on their new bikes called Epic Pursuits, and drove down through pretty much like ran the coast down to Cambria all the way, just outside of like Monterey. We ended up cutting over, dropping coming through that whole park, coming over, Santa Ynez and dropping in through Bakersfield and coming back all around, and basically rode from San Francisco down to Joshua Tree. And, I went to school at Berkeley. And then, obviously grew up in Southern California. Okay. So I had friends that I played with that were, from that central area. And like, I had never done that. Yeah. And driving through California, it's the most beautiful place, and especially Santa Barbara and that whole area, like to Cambria. If I ever move back to California, like Cambria and that area is the only place I'd ever live.
It's quite legendary, but so is the cost. So is the cost.
Well, I mean, it's I mean, my reasons for leaving California have to do more with I couldn't pay into the system anymore in California. And we were also doing some military contracting that necessitated a move and some of these things. And then COVID hit and I figured, fuck it, we'll just stay here. It's still the most beautiful place on the planet. And, riding through like this, the redwoods, south of San Francisco and the sequoias and coming through and like riding the coast on PCH and being like, oh my God. So when you said Santa Barbara, I was like, oh yeah, I'm well familiar. God, what's the hotel we used to go to? Not Terranea, that's in Southern Cal, or that's in Palos Verdes. But God, there was that hotel we used to go to that was all like stone in Santa Barbara. Fuck, I can't remember for the life of me. But yeah,
it's in Santa Barbara.
Yeah, it's God, it's like a big resort.
I'm not. What general area was it in?
God. Well, go on. I don't want to. Oh shit.
Well, either way, yeah.
It's amazing. Yeah. Well, where were you before this? Where were you before?
Yeah. So I grew up in Tallahassee, Florida. I met my wife there, and then that's when I was in Florida State for exercise physiology, and then we went down to Tampa because I was in the College of Medicine program there for biomedical, and my wife. Yeah.
I used to live in Tampa when I played for the Eagles. I lived in Tampa. I lived in right down in Hyde Park, and then I bought a place. I bought a place in Safety Harbor, right on the other side of the Causeway. So I lived there for a number of years, and then when I went to the Chiefs, I moved back to California and just kind of home based in California. But I had a great time living in Tampa. I thought it was one of the best places when we were looking at moving out of California. My wife was lobbying for here in Austin. I actually lobbied for Tampa. I would have gone back to Tampa in a heartbeat.
Well, man, I'll tell you, Tampa is like, it was about 10 years ago. It was like one of the cheapest places to live too. It was below the mean housing price. It was like 0.7 versus the 1 reference range. And it was wonderful. International airport. It's not like it's so big of a city where you can't drive in and out in like hour and a half, and even during rush hour, it was pretty good. Yeah. We lived in the New Tampa area, and it was wonderful. I definitely loved my experience in Tampa. Lived in Pensacola for a short period of time. And then also went out to, because I was at the Institute for Human and Machine Cognition, which I think you're familiar with.
Oh, yeah. Then, Ken Ford. I mean, another good friend and also follower of a ketogenic diet, had strokes or seizures. And
Ken's a man. Yeah, Ken's an incredible person. Yeah.
Yeah. Not only probably I would say one of the smartest people I know, but for some reason thinks I'm smart, which I actually am. Like, I was like still get Christmas cards from him, and like I'm like, the fact that Ken Ford thinks I'm actually smart, like it's a pretty good. He brought me in on a deal where they were trying to lift weights in space. And I went in their lab and completely blew up like $3 million worth of research. And like these guys were trying to design this thing, but none of the guys that he had designing it had ever lifted weights. So they didn't really understand the mechanism of loading. And they were trying to do he like went in there and he's like, don't talk to the investors. Like, but yeah, I love Ken. He's in Wyoming. Yeah. He built a place in Wyoming and sends me these pictures and fuck, I like that dude so much.
Yeah, there's some super, super, super great, brilliant people there, and Ken's the man, and I met a lot of amazing people. I love my time that I had there, and a lot of what we got to do with the Department of Defense, and it was wonderful. Yeah, one of the best experiences I've ever had in research was actually getting to work with some of the military communities there, because when you meet someone, you shake their hand, and you realize they were willing to give it all up.
Yeah,
not for themselves, but like for everyone else. I mean, that was a special, unique situation and experience to meet a person. There's nothing quite like that, but that was really, really special. It's cool, Ken, he's the man. And
did you meet Dr. Ants from? He was the head of Regen for Andrew's Institute. He also did Ken's shoulder surgery, and they were connected to the Exos place.
So I've done some communications with him. I never met him.
Oh, okay. Yeah, no, he ended up doing my shoulder surgery.
Cool. All right.
When I was down there visiting Ken, I sat next to him at a private dinner, and he had been a fellow for Dr. Stedman, who was the guy that did my knee in Colorado, since passed away. Fucking amazing dude. And so there was a kind of a tree of that, and then he went to work for Dr. Andrews, so I ended up going down and he did my shoulder scope, and we're still pretty friendly. But
awesome. Yeah, cool.
Yeah. Well, dude, fuck, dude, that was amazing. I felt like we could talk for hours. I mean, we obviously have not a hard stop, but like, we get to like the 6 hour mark, people tend to stop tuning out. But like, I mean, this is like it's amazing to connect with somebody of your magnitude that has this experience. And, as me as, on the other side of this thing, managing my son, it's not only great to not feel like you're kind of siloed, because I think so often with this type 1 thing, you kind of feel like you're alone, like it's me and my wife and this, and there's stuff on the internet and you read, and these doctors aren't necessarily in. You're kind of stuck in this, so it's incredible to connect. And I thank you so much for taking the time.
John, you're the man. I truly appreciate you taking the time and advocating for this, and also doing everything you can to help your son. I'm a infinite. Maybe that's undersells it. I completely commit and believe that your son will be better for it. It has completely gifted my life with an experience. I'm speaking to you today. I get to meet other people who can resonate with this experience. There's nothing. A lot of people struggle to find their why in life. Like, what's my thing? What do I care about? Type 1 diabetes immediately made that simple. It is this. And I truly believe that almost every great experience or great achievement I've ever had in my life was frankly as a result of a pretty low. A very low time in my life. And the lower the low, the higher the high was afterwards. And type 1 diabetes was exactly that. And it was one of the best gifts I've ever had. And I fully believe your son will be as strong or stronger than his peers, as healthy or healthier than his peers. And frankly, having this opportunity will give him the opportunity to give him a gift that he can share with other people that is unlike, frankly, maybe anything else. And for that, man, I respect what you and your wife do and the advocacy you put towards this, and how powerful and passionate you are towards this topic. So thank you for that.
Yes. I mean, dude, I'm humbled. Is it cool? I'm going to reach out to you once this ends. I'm going to shoot you an email. If I ever have any questions or run into anything and need like Who Wants to Be a Millionaire Lifeline, I would,
John,
can I reach out?
We're staying connected, man.
Okay.
For
awesome.
Sure.
Thank you so much. Thanks for tuning in to another episode of Power Athlete Radio. Hey there, Power Athlete Nation. Big shout out to all the heavy hitters who stuck around till the final whistle. If you've been soaking in the knowledge bombs and epic tales we've been dropping for free, here's your chance to be a game changer. Swing by kofi.com/powerathlete and toss a few bucks our way to keep the podcast fueled and firing on all cylinders. That's ko-fi.com/powerathlete. Your support makes a difference. See you.